Hello. So good evening, doctors.
Good evening.
Good evening.
So on the behalf of Corona Remedies Private Limited, I welcome all the delegates and our faculty also for the webinar. So just I am going to share a screen.
Hello. Speaking.
Okay.
Yeah, hello. Hello. I am in a meeting. Can't really discuss things with you for next 2 hours. Little later, maybe tomorrow morning.
Okay. So I am welcome you on the platform. There is a Zoom platform. 122nd edition of our Happy Learning Masterclass webinar, which is associated with the State Organization of Gynecology and of Society, which is jointly of the Gujarat, which is jointly done by Bharuch, Navsari, Surat, Valsad, and Vapi Obs and Gynaec Society. First of all, I would like to welcome our MOC, Dr. Suman Sinha, in this platform. Right now, I can say that Dr. Suman Sinha is currently president of Ranchi Obs and Gynaec Society, which is for 21 to 23. Okay. So along with it, right now, Dr. Suman Sinha is a senior consultant in OBS at AH IVF Infertility Center, Ranchi. Along with it, she is a director of Advanced Care and Maternity Center. And she was associated with many societies right now, currently she is president of OBS and Gynaec Society of Ranchi. But earlier also she was associated with the this SO VSI Bihar and Jharkhand chapter, and also executive member on ISOPAB. Dr. Suman Sinha.
Okay. So
Dr. Suman Sinha was chief of medical service and HOD of Obs and Gynaec in CCL Hospital, Ranchi. Okay, and she has attended as a faculty in many national and international conferences, and she has many publications also. Okay, so she got many awards and appreciations like Dr. Durusha Award and also Best Paper Presentation Award in national conferences. So I welcome Dr. Suman Sinha in this Zoom platform. Okay, along with it, I also welcome our coordinators, Dr. Kalpana and Dr. Jyoti Banglowala. When I can introduce the doctors, that is Dr. Kalpana, who is Dr. Kalpana, who is a Madurai Obs and Gynaec Society president. Okay. And currently she is practicing in Guru Hospital. Okay. Along with it, she is having a responsibilities in as a course director for postdoctoral fellowship in endogynecology. She is also associated with the as a national coordinator in FOXI committee member of the infertility, and also she is a chairperson of TNFOG. Okay, that is the Tamil Nadu Obs and Gynec Society. She is also associated with Madurai chapter, that is PISAR, okay, and also secretary of MOGS. Okay. She was also awarded with many awards like Best Doctor Award by the Madurai University, okay, and also Medical Excellence Award awarded by the Governor of the Tamil Nadu. Okay, so she got a good achievement also. And also, I would like to welcome Dr. Jyoti Banglowala. Okay, currently she's Dr. Jyoti Banglowala was the secretary of Indore Obs and Gynec Society, that is the IOGS, and she is also having a keen interest in high risk pregnancy and consulting the many cases of high risk pregnancy and solve out the problems of the patients. Okay, and she is having also published many papers and associated with the like educational awareness campaigns.
Mehul ji, all are from our family only, all Gujarati our family.
So
Okay.
let's move on to
Go ahead.
the lamp lighting, please.
Yeah, sure. So I am going to this lamp lighting. So after that, I am going to hand over this session to our MOC, Dr. Suman Sinha. So please, Dr. Suman Sinha.
Thank you. Can you hear me now?
Yes.
Yeah.
Yes.
Thank you. Thank you for the very kind introduction. Good evening, everybody. After invoking blessings from Almighty, I, please mute everyone. Please mute everyone. Yeah, thank you. Good evening, everybody. After invoking blessings from Almighty, I, Dr. Suman Sinha, President Ranchi Society, and MOC of today's webinar, take the delightful opportunity to welcome all the delegates and dignitaries to 122nd Happy Learning Masterclass webinar series in association with Bharuch, Navsari, Surat, Valsad, and Bhapi OB-GYN societies. At the very outset, I am humbled to extend my warmest welcome to our revered guests of honor, Dr. Vipul Kapadia, Dr. Bhavna Seth Madam, and Dr. Kamini Patel Madam. We are honored to have you on board. I welcome our program director, the person behind the show, Dr. MC Patel sir. I welcome all the conveners, Dr. Narendra Gajjar, Dr. Sneha Bhuyar, Dr. Asa Jain, Dr. Rekha Rajinder Kumar, for supporting us in making the program. I also welcome the coordinators, my friends, Dr. Kalpana and Dr. Jyoti, for always standing by my side. I welcome all the luminary distinguished speakers, the moderators, the chairpersons, and the panelists for very meticulously preparing their subjects to enlighten us on the recent updates in obstetric and gynecology. Our topic of today's discussion is a mixed bag, where we are going to hear right from the infertility to sudden obstetrical collapse to the medical legal issues in ART. So all the topics are very catchy and very, very useful. I welcome our academic partner from Corona Remedies, for supporting us in all aspects. I welcome all the viewers who have joined today. Their vibrant participation in this program will make our program a big success. Now we take the honor to introduce our conveners. So first of all, since Dr. Asa Jain is not here, I'd like to introduce Dr. Rekha Rajendra Kumar, madam. So can I have her CV, please? As we all know, Dr. Rekha, madam, is a very dynamic personality and very particular in everything. She has a superb academic background. She's first ranker in MD, 7th ranker in MBBS, and already a topper in ICOG reproductive medicine exam. She's practicing gynecology for past 31 years. And presently Vice President of Bangalore Obstetric and Gynec Society, and also South Zone Coordinator in the Foxy Infertility Committee. There are lots of awards and felicitations to her credit, as she is also a PG teacher of MS Ramaiah Medical College and published more than 15 original articles, 1 case report, and 1 poster presentation in gynae conferences. She has given more than 100 radio and TV talks and 40 newspaper articles on women's health. So, madam, I welcome you to this webinar, and also I'd like you to introduce our program director, Dr. MC Patel, sir, for the official welcome address. Over to you, Rekha, madam.
The opportunity of introducing none other than our dearest sir, with whom we are associated since such a long time. Sir really needs no introduction, does not need any introduction, but as a formality, it's my duty to introduce sir in the podium. Can I have sir's CV?
So, Rekha, no much
Yes,
detail.
sir. I'll just tell 1 or 2 lines, sir.
Yes. It will do.
Dr. MC Patel, sir, he has been conducting this program, and we have finished more than 120 programs of the Happy Learning webinar series, where sir has been touching each and every small society possible, not only involving the esteemed faculties, not only getting the important topics, all practical topics, very important for PGs. This is one very important, useful thing where he's touching nook and corner of India. Not only that, I would also tell that every time sir will have a topic so that he will raise awareness about medico-legal issues which are pertinent to that topic in every session what we had so far, more than 100 of these sessions. Much more than that, sir is available to all of us, that is obstetrician, gynecologist, whenever we need him at any time, and many people have taken his help even at very odd hours. Sir has helped at even midnight many of these people, and has given not only the lot of practical tips, he has also given lot of mental support to many of the obstetrician gynecologists where they were in real difficulty. This is sir's official CV. Sir is telling me not to read this, as
Yes.
all of us know about this. I have just given some unknown facts about sir to some people. Thank you, sir. It's my esteemed opportunity to introduce you, and welcome to the program, sir.
So, thank you, Rekha, for kind words. It gives me immense pleasure to welcome my own Sugog societies and all the friends. I welcome Dr. Vipul Kapadia, who has kindly consented to be guest of honor to bless us for this webinar. He is good academician and good clinician, and always with us in any of our academic activity. So welcome Dr. Vipul Kapadia, sir. I also welcome Dr. Bhavana Ben Seth, one more senior faculty from Bharuch. So she is also always interested to be associated in academic activities. So welcome Dr. Bhavana Ben. I also welcome Dr. Kamini Patel, President SOGO. She is busy with one meeting. She may join at any time, but in her absence, we welcome Dr. Kamini also. I also welcome 2 learned speakers for today's webinar. Dr. Akash Gajjar, a young IVF specialist from Chikhli, and he is going to discuss very important topic for today's webinar, that is azoospermia. I also welcome one more young faculty from Surat, Dr. Sejal Nayak, and good endoscopic surgeon. And she is going to talk about laparoscopic fertility enhancing surgery in case of endometriosis. I also welcome two learned moderators who are going to moderate very interesting panel, that is sudden obstetric collapse. Dr. Prakash Bhatt from Surat, very senior gynecologist and past president of FOXY, past vice president of FOXY. And one more moderator, Dr. Hiren Thakkar, president of Bharuch OBGYN Society. They are going to moderate the panel. I also welcome two learned expert panelists, Dr. Sneha Buyar. Of course, she is busy with one meeting. She may join little later. But Dr. Rekha Rajendra Kumar, she is also with us in this series since long as an expert panelist. She will put her expert comments during panel discussion. I also welcome all the learned panelists who have joined this webinar as a panelist. Dr. Praful Doshi from Surat, Dr. Kuresa Kuresi Madam from Valsad, Dr. Jayshree Jana Kapadia Madam from Vapi, Dr. Prachiti Mawani Madam from Valsad, Dr. Yogini Rolekar from Valsad, Dr. Hiral Pandya from Bharuch, Dr. Darshan Wadekar from Surat, Dr. Satyan Kasabwala from Navsari, Dr. Kinjal Mangukia from Surat. I also welcome all the chairperson who have kindly consented to chair respective session. Dr. Dipti Patel from Surat, Dr. Ravindra Korat from Surat, Dr. Pooja Agarwal from Vapi, Dr. Nupur Chasetia from Surat, Dr. Nital Patel from Valsad, Dr. Manpreet Patel from Vapi, Dr. Mitali Thakur from Valsad, Dr. Jagruti Ben Desai from Surat, and senior from Surat, Dr. Sandhya Chasetia Madam. I also welcome three convener, Dr. Narendra Gajjar, and I put it on record, Dr. Narendra Gajjar has helped me a lot, not only designing this program, but to execution of this program. And Narendra Gajjar is good old friend. He is always with me in any of my academic activity. So welcome, Dr. Narendra Gajjar. I also welcome Dr. Sneha Buyar and Asha Jain as a convener, and two co-moderator, Dr. B. Kalpana from Madurai and Dr. Jyoti Banglowala from Indore, and of course, Master of Ceremony from Ranchi. So all these teams, convener, coordinator, and Master of Ceremony, they are since long with me in this series, and I am happy to announce this is our 122nd edition of Happy Learning Masterclass web series in a sequence. So in era of COVID-19, where physical meetings were not possible, we four friends started this series to meet our Foxian friends on virtual ground to say hello and discuss very important topic of our day-to-day practice interest. And this series started, and now I am happy to announce that today we are more than 7,000 plus member of Happy Learning Masterclass series in this series. So welcoming you all, and we have today we have selected very interesting topic for discussion, and I am quite sure that it will be benefited all the delegates and whosoever have joined this webinar. So welcoming you all, and this is in association with SOGO, our state organization of OBGYN, and all the society of South Gujarat, that is Valsad, Vapi, Surat, Navsari, and Bharuch. I welcome President and Secretary of respective societies and all the delegates who have joined this webinar. So thanking you all and welcoming you all. Over to you, Suman, for further proceeding. Thank you very much.
Thank you so much, sir, for the welcome address. And again, I will request Rekha Madam to invite, introduce, and welcome Dr. Vipul Kapadia, sir, our guest of honor.
Yeah.
Please show his CV.
Yeah, I'm so happy to introduce that I feel it's a very noble and prestigious task that is given to me to introduce such a senior gynecologist obstetrician, Vipul Kapadia sir. I'm very happy to introduce sir to the forum. If can I have
share the
Dr.
CV?
Yeah.
Yeah.
Yeah, Dr. Vipul Kapadia sir is the director of Ramaben Hospital, Navsari. Sir is also director of Namaha Healthcare, Mumbai. Sir is a past president of State Organization of Obstetrician Gynecologists of entire Gujarat state. He is the past president of Navsari Medical Association. He has had extensive training in ultrasound, assisted reproductive technology, and reproductive endocrinology at various centers in USA, UK, Belgium, Australia, as well as Singapore. Sir has special areas of interest in not only the ERT ultrasound, but also on other fields like vaginal surgery, high-risk pregnancy, and reproductive endocrinology. Such a rich CV, sir. He is also an invited faculty in many of conferences and workshops with a great academic experience. Sir, we heartily welcome you to grace the occasion, and we also want you to give us some pearls of your wisdom, sir, because you have had such a vast experience over so many decades. Sir, please unmute yourself, sir.
Vipul bhai, you are muted. Yes. Vipul bhai, you are muted. Please unmute.
Am I being heard now?
Yes. Now you are audible.
Good evening to all of you. It has been an honor to be a guest of honor at such a prestigious platform. I have been wondering what an impact this happy learning master classes have made to a practicing gynecologist. It's all thanks to Corona, yes, but more so to Dr. MC Patel and his team. Remember that it is 122nd edition. Wow, that's really calls for 3 claps, right? And what selection of topics he has made today. The topics not only have a hello around the topics, but also have an enigma. First, male infertility management. We all are aware how difficult it is. Second, fertility preservation, especially with laparoscopic surgery. We all know how difficult and challenging it is. And thirdly, negligence in ART practice to be delivered by Dr. MC Patel himself. And above all, the biggest impact is going to be made by the panel discussion topic, and that is sudden obstetric collapse. We all have faced this sometime or the other in our practice. And I think we'll be signing off at the end of this topic with very, very wise thoughts and practical guides to our future practice. Thank you, Dr. MC Patel, for inviting me. And I wish you very, very good luck for the whole webinar today. All the best.
Thank you very much, Vipul bhai, for sparing time to bless us. Actually, when we started this series, our goal was to discuss very important topic which is useful in our day-to-day practice and to be helpful to our patient and to check maternal and infant mortality was the aim. Because by 2030, Government of India and WHO has given us a target that maternal mortality should be 76 and infant mortality should be 12. And I am happy to announce Gujarat is well ahead in this maternal mortality. We are having 57 just now. But, and of course, there are few states in southern India, they are having maternal mortality nearby 30. But at the same time, there are few states in northern and particularly in northern eastern India that they are having maternal mortality near 200 and even more than 200. Say, for example, if I quote state of Assam, having 195 maternal mortality rate. So to check this, and it could only be possible due to joint hand. If you go joint hand on part of government, NGOs, federation like FOXY, IMA, and particularly obstetrician friends who are working in remote rural India. And if we go hand in hand, then only we can check this maternal mortality and infant mortality. So with this aim, actually, this series was started in era of COVID, where physical meetings were not possible, to say hello to our Foxian friends and to discuss focus topic. And that is why sudden obstetric collapse is the topic for today's discussion. Considering, thank you, Vipul bhai, again for sparing time to bless us.
Thank you, Vipul sir. As you have said, sir has crafted very carefully, included topics from all spectrum, ART, endoscopy, medical, legal, and then very important, the obstetric.
Thank you, Vipul sir, for your pearls of wisdom. And now I take the privilege and opportunity to invite and introduce to the gathering Dr. Narendra Gajjar sir. Sir is the president of Navsari OB-GYN Society, and he has been past president of SOGOG. I think that is Gujarat Society. SOGO is Gujarat Society. Okay, and he's been practicing gynae at Asirwad Hospital and Akash IVF Center since last 37 years. He has a huge experience and has achieved many prizes and awards for academic achievements. He has participated in many state and national level conferences as speaker, panelist, moderator, judge, and demonstrated NDVH surgery in many conferences. And he has the credit of organizing many conferences like Mid-Term Conference of SOGOG, the SOGO, then West Zone Yuva Conference. Welcome, sir. And I request you to introduce, welcome, and invite our guest of honor, Dr. Bhavna Seth, madam. Over to you, sir.
Thank you, Dr. Suman. Thank you for nice words. And it's a proud privilege for me to introduce our guest of honor, Dr. Bhavna Seth, today in this Happy Learning Masterclass webinar. Before that, I would like to mention few words about our program director, Dr. MC Patel, who has taken a mammoth work not only to educate our obstetricians, but also to spread the awareness of health and maternal mortality reduction all over country. I would like to mention my co-conveners, Dr. Sneha and Dr. Asha, and guests of honor, of course, Dr. Vipul Kapadia and Dr. Kamini Patel, along with Dr. Bhavna Seth. So, Dr. Bhavna Seth, senior gynecologist and menopause practitioner since last 43 years, practicing in Bharuch. She was the past president of IMA, IMS, Obstetric and Gynec Societies of Bharuch, and to her credit, she has organized state conferences in 1992, 2006, and 2018. She was the past co-chairperson of IMS Rural Committee. She has been awarded as the best young gynecologist in 1995, and she has contributed to a book, author of the book, Antidote to Aging. I would like to add something more to Dr. Bhavna Seth. She is a very nice human being. She is a very good practitioner, and she has always contributed for the welfare of SOGO. So, Dr. Bhavna Seth, please give your blessings to today's webinar.
Thank you, Gajjar sir, for such kind words. And I'm really delighted to be the guest of honor for this function. I know Dr. MC Patel very closely, and he has worked very hard for such, I think, happy learning. We are lucky that we have Dr. MC Patel with us. We meet him in person, and he's ever ready to help us anytime, any member. And that is why we are very relaxed that we are not worried about any medical legal cases. Now I must tell about this webinar, that this webinars are very interesting and very practical topics he always chooses. It's very much beneficial to postgraduate students. And not only that, but it also helps us And I think our maternal mortality rate and infant mortality rate has gone down. A part of it, the credit should also go to Dr. MC Patel, who has helped us. Even they have become very practical. So I wish this webinar and such webinars he continues for long. Thank you very much for inviting me. Thank you.
Thank you, Bhavna Ben, for sparing time to bless us. Of course, you are always with us in any of our academic activity. Thank you very much.
Thank you, Bhavna Madam, for giving such nice words to our webinar. Thank you so much. And now I take the opportunity myself to introduce and welcome Dr. Kamini Patel, Madam, our next guest of honor. Madam is not here, but I'd like to introduce her to the gathering. Madam is the founder director of Vani IVF Center, and she's also IVF specialist and senior IVF consultant at Care and Cure Hospital. Regarding her professional bodies, Madam is presently president of SOGOG. She's also president of Ahmedabad Obstetric and Gynecological Society. She is honorary secretary of Ahmedabad. She had been honorary secretary of Ahmedabad Obstetric and Gynecological Society from 2018 to 2019. And she is also national international speaker. And she has taken part in the menstrual hygiene program of HOPSI. She was secretary in critical care in 2017 at Gujarat Society, probably. She joint secretary of she was a joint secretary held in Ahmedabad in 2016. Lots of research was is to her credit. Many publications she has authored. So if Madam joins, then we'd like to hear from her. So I think is Madam there?
No, I do not see. So we can proceed accordingly.
Yeah.
If she joins, we will have blessings from her at that time.
Yes, sir. True, sir. So with this, we are going to end our inaugural function, and we move on to the academic part of our program, which is the main part of our program. And for this, I'd like to hand over to the coordinators, Dr. Kalpana and Dr. Jyoti Banglowala, for this. So over to you, Dr. Jyoti and Dr. Kalpana.
Thank you very much. And good evening, everyone. From the Bharuch, Navsari, Surat, Valsad, and Vapi Obs-Gynae societies, and especially our guest of honor, Vipul Bhai Kapadia, Dr. Bhavna Sheth, and Dr. Kamini Ben Patel, and Dr. Narendra Gajjar. Special thanks to Dr. MC Patel, who always tried to spread knowledge and creating awareness about the medical legal aspect. And everyone everyone can witness about the medical legal awareness he created. Everyone is very now careful in taking consent, doing counseling, doing documentation. This is the beauty of this webinar. So everybody is so aware. So we can see the medical legal litigations are also now coming to very low side, and everyone knows how to proceed now and how to take help. And the surgery is always ready. And I'm so thankful for this particular webinar for sir. And now we are moving to our academic session. Our first session is management. In our first session, the topic is management of azoospermia by Dr. Akash Gajjar. For this, I'm inviting the chairperson, Dr. Deepti Patel. Mehul Bhai, please show the CV. Dr. Deepti Patel, Madam, is past president, Surat Obs-Gynae Society. She is director of Love and Care Multi-Speciality Hospital since 1990. And her special interest in infertility, endoscopy, high-risk pregnancy, and cosmetic gynecology. She is vice president of Indian Medical Association, Surat, and treasurer, Surat OBGYN Society Education and Charitable Trust. She is active member of ISHRE and past president of Surat OBGYN Society, and doing Love Tapi Care Tapi, an environment project for Tapi River by Love and Care Charitable Trust. We welcome you, madam. Our next chairperson is Dr. Ravindra Korat, sir. He is secretary, Surat OBGYN Society. He has passed MBBS from SMIMER Medical College with gold medal and MS for GMC Gujarat. He has had special training, intense training in advanced infertility within PGD and PGS with Wings IVF Ahmedabad and IVF training at Manipal, Bangalore. He has participated in various national and state level conferences and workshops as a faculty and youngest trustee in the Dayanand Social Trust working for the tribal girl. We welcome you, sir. Our third chairperson is Dr. Pooja Agarwal, madam. She is Secretary of OBGYN Society. She is MBBS from SNMC Agra and MS OBGYN from GMC Surat. She is FMAS Consultant Obstetrician and Gynecologist at Pooja Hospital, Daman. And at present, she is President Secretary of OBGYN Secretary Society. I request Dr. Deepti Patel, madam, to give the introduction for our speaker. Dr. Ravindra Korat, sir, for opening this topic, and Dr. Pooja Agarwal, madam, to conclude this topic. So handing over the mic to Dr. Deepti Patel, madam.
Good evening. First of all, I would like to thank Dr. MC Patel, sir, for giving us highly popular academic programs. I am feeling very happy to introduce young and promising IVF specialist and embryologist of South Gujarat, Dr. Akash Gajjar. Akash Gajjar is gynecologist, IVF specialist, embryologist working at Akash IVF Center in Asirvad Hospital. After his postgraduate study in gynecology, he passed the fellowship in clinical embryology from Nasik University and became university certified embryologist in 2014. He presented many papers and delivered talk in state and national conferences. He presented a paper in virtual conference of 2020. And above all, he is very humble and excellent human being. Over to Akash Patel, Akash Gajjar, for his talk on management of azoospermia. Thank you.
Before Akash takes over, any opening remarks from Dr. Ravindra?
Yes. First of all, I like to congratulate Dr. MC Patel sir and your team for beautiful execution of total 120. From Surat Obstetric and Gynec Society, I heartily welcome all of you. As all of you know, azoospermia is very common problem in day-to-day prevalence and of azoospermia is increasing day by day, and simultaneously there are new horizon for treatment of azoospermia is arise, both medically and surgically. To enlighten this all treatment, we have beautiful young academician Dr. Akash Patel is with us. So over to Dr. Akash Gajjar sir.
Yeah, good evening, respected seniors and the dear colleagues. First of all, I would like to thank Sogog and especially Dr. MC Patel sir for giving me this opportunity to talk on a very tricky topic, that is azoospermia. Because when you label a person as an azoospermic, it has a very devastating psychological impact. So in this talk, I would like to talk about how to diagnose azoospermia, what are the etiological factors, and how to manage a case of azoospermia so that patient can have his baby by his own sperms. So please, Mr. Mehul. Yeah. Next slide. See, if we see the incidence of infertility, it is around 15% of the couple. But if we see in our OPD practice, daily we can get 4 to 5 new cases of infertility, and male factor, according to the books, it is around 30 to 50%. But if we see our center statistics, it is around 65%. So rising male factor infertility is a very worrisome factor. And out of all this, 15 to 20% are azoospermic. Next. If we want to define a person as an azoospermic, then at least we have to separate centrifuged semen samples. Centrifugation at the speed of 3000 RPM for at least 15 minutes, and we have to examine a pellet. So we cannot label a person as an azoospermia based on a single semen analysis report by a pathologist. Ideally, a semen analysis should be performed by an andrologist, and ideally it is to be repeated on 2 different occasions and properly abstinence period. Next. So if you want to evaluate a person, The idiopathic male infertility, it is around 60 to 75% cases. And the proper history taking, like the fertility history. And believe me, the husband is a most neglected person. According to counseling, when you counsel a patient, the husband is most of the time seated outside. But we have to include husband. We have to take the proper history from the husband, and we have to examine the husband, because many of the times female gynecologist or sometimes male gynecologist also, they do not examine a husband. So many times the etiological factor can be missed out. So according to the history points, age, duration, primary or secondary infertility, libido, prior treatments, and occupational hazards like the welding, coal mining, chemical exposure, when the temperature is high. Always ask for the general health like diabetes, for ejaculatory dysfunction, erectile dysfunction, and respiratory illnesses. Smoking, it's a very common. Reactive oxygen species lead to the sperm DNA damage, genitourinary infections, and the STDs may lead to the obstructive azoospermia. Next. Prior surgeries, especially testicular cancer, varicocectomies, testicular torsion, undescended testes, that all have to be inquired. Medical history, the steroid abuse, it's very common nowadays, especially in a person who are gym going. Antibiotic high dose, nitrofurantoin, sulfasalazine, 5-alpha reductase inhibitor. If a person has to undergo chemo radiotherapy like gonadotoxic drugs, then always consider cryopreservation of the sperms before starting the chemotherapy. Alcohol and recreational drugs always have a very bad effect on the sperm parameters. Examine a body habitus like the Klinefelter syndrome. Obesity, excess obesity lead to the leptins, and will decrease the testosterone and increase the E2 level and eventually lead to the sperm DNA fragmentation. Blood pressure, hypertension may lead to the erectile dysfunction. Always look for the secondary sexual characters, high pitch hypogonadism voice, and the gynecomastia. Scrotal examination for cryptorchidism, hydrocele, testes, epididymis, size of the testes, if the long axis should be minimum 4.6 centimeter and the volume of the testis by the Prader orchidometer, minimum volume should be 20 ml. And the consistency of the test is soft in the hypogonadism and the hard in the tumor, and the epididymis is usually not palpable usually. Spermatic cord, varicocele, it's common 11% of the men with the normal semen analysis and the 25% with abnormal semen parameters. Bilateral absence of the vas deferens, phallus, epispadias or hypospadias, penile curvature, prostate and the seminal vesicles examination, and the, if possible, do the PR examination for the hypoaplastic prostate in hypogonadism. Seminal vesicles, usually they are not palpable, but abnormal engorgement lead to the ejaculatory duct obstruction. Endocrine evaluation, when we see the semen abnormality, the sperm concentration which is less than 10 million per ml and impaired sexual function, then go for the hormonal analysis. If we see this chart, if we see the FSH, LH, testosterone, inhibin B, they are normal in obstructive azoospermia. But if we see the hypo, that is a hypogonadotropic hypogonadism, all values are low. And the hypergonadotropic hypogonadism, the testosterone and inhibin B are low, FSH and LH are high. So based on this endocrinological evaluation, we can differentiate between the obstructive and the non-obstructive azoospermia. Next. See, this is the semen analysis WHO guidelines. If we see the normal forms, it is around 4%. Previously, it was reported to be around 14%. So WHO has lowered down the semen parameter from 14 to 4% of the normal sperm because of the globally there is a decline in the semen parameters. So at least 4% of the normal sperms are required to have a pregnancy. Next. Alkaline pH, it is a normal. In acidic pH, obstruction or infection. Fructose, in obstructive azoospermia, it is absent, and the non-obstructive azoospermia, it is a positive fructose test. Next. Radiological evaluation, when required, in form of the transrectal ultrasound for the low seminal value to allow obstructive azoospermia and the ejaculatory duct obstruction, the seminal vesicles AP diameter should be more than 1.5 centimeter. And the vasography, it is a rarely performed investigation, but after vasal reconstructive procedure, like hernia or pelvic surgery, the semen volume which is less than 1 ml, fructose negative azoospermia with palpable vas. To differentiate between the obstructive or non-obstructive, we can go for the testicular biopsy. and to assess the presence or absence of focal spermatogenesis in non-obstructive azoospermia. If it is found, then we can use those pumps for the IVF or ICSI. Next. So if we broadly define the azoospermia, it is obstructive and the non-obstructive. Next. Idiopathic, post-surgical like the vasectomy, hernia repair, prostatectomy, congenital bilateral absence of the vas, post-infection, and the ejaculatory duct obstruction. Either normal or enlarged epididymis, palpable or non-palpable vas, but it has a normal size testis. And the semen analysis, either normal volume or low pH, and ejaculatory volume may be normal in case of erectile dysfunction or congenital bilateral absence of vas. But hormonal parameters are within normal range. Genetic testing for the cystic fibrosis gene mutation in a male with particularly congenital bilateral absence. Testicular biopsy, it will reveal the normal spermatogenesis. So if we see the obstructive azoospermia patient with a low volume and the absent fructose, always examine the vas. If it is palpable, then either it will have the ejaculatory duct obstruction, either go for the transrectal ultrasound, cystic seminal vesicles and ejaculatory duct, then we can go for the transurethral resection of ejaculatory duct. Or if we have a fibrous or normal seminal vesicles, we can have the sperm by the PESA and we can do the ICSI. But if we have the retrograde ejaculation, when we can do the urine analysis, and from urine analysis, we can recover the sperms after alkalinization of the urine, and we can use those sperms. If it is not palpable, then it is absence of the bilateral vas, and either we can go for the donor insemination or either with the ICSI after genetic study. Next. Intrauterine insemination of the epididymal sperm, the 3 to 5% of the pregnancy rate. And if we do the PESA and ICSI, the 30 to 40% of the pregnancy rate. Surgical correction of obstruction, which obviates the need for ART and the retrieval of the sperm from the male reproductive system for the IVF or ICSI. So surgical treatment may be microsurgical reconstruction of vas and or epididymis, and the transurethral resection of a ejaculatory duct in case of a duct obstruction. And the duct obstruction may be due to previous genital infection, calcification, stones, TB, or previous surgical trauma, may be cystic and fibrous. So infertility is a common symptom, scanty or ejaculation, hematospermia, pyospermia, or dysuria, where the duct enters the distal prostatic urethra near the verumontanum. 25% pregnancy rate following the transurethral resection of the ejaculatory duct. Next. Men with obstructive azoospermia, vaso-basal anastomosis, or vaso-epididymostomy in a younger couple, which is less expensive, conception can be achieved by the natural means with a proper anastomotic procedure, but high failure rate and need for surgical expertise. Next. Normal spermatogenesis on a testicular biopsy, but no sperm is aspirated from the vas lumen. Secondary epididymal obstruction, vaso-epididymal ductal end-to-end anastomosis, triangulation technique, and the longitudinal intussusception vaso-epididymostomy. Following vaso-epididymostomy, sperm is present in ejaculate of 85% of the patients. Vaso-basal anastomosis following the vasectomy, it is around 2 to 6%, or vas injury in a hernia repair, it is around 6%. Fluid from proximal end of the vas, which is analyzed before any surgical procedure, and it is multi-layer microdot technique with the 10-0 monofilament nylon suture material, and the vaso-anastomosis return of the sperm to ejaculate in 70 to 95% of the cases. Spontaneous pregnancy rate is in the range of 10 to 75, and the fluid analysis, if it is a clear fluid and the sperm is positive, then this procedure is helpful, but vas is dry and there is no sperm, then vaso-epididymostomy procedure is helpful. Sperm retrieval technique from the testis as a primary therapy for the obstructive azoospermia and for non-obstructive azoospermia, or as an adjunct to the microsurgical reconstructive procedure in a case of obstructive azoospermia. Obstructive azoospermia with congenital bilateral absence of vas, failed vaso-epididymostomy, and the older couples. Next. Which are the sperm retrieval techniques? We have the PESA, microsurgical epididymal sperm aspiration. We have a TSA or micro TSA or percutaneous testicular sperm aspiration. So if we see all the different methods, they have some advantages as well as the disadvantages. Out of all the PESA, it is fast, no microsurgical skill, and minimum post-op discomfort. And if we see the TESA, microsurgical epididymal sperm aspiration, the large quantity of the sperm are obtained from the ICSI. TESA or micro TESA, no microsurgical skill except when do the micro TESA. And the percutaneous testicular sperm aspiration, it is fast, easy, minimal discomfort, and minimally invasive procedure. So all these procedures, they have some disadvantages also. Next. TESA or micro TESA, which is preferred in non-obstructive azoospermia and failed MISA. In obstructive azoospermia, it's a mesoepididymal sperm aspiration or PESA is preferred. No difference in using fresh or frozen sperm sample in fertilization rate or pregnancy rate. Next. So some of the recent advances in the sperm retrieval techniques, it's a multi-photon microscopy, means low energy infrared femtosecond pulse laser, which excites the photon and produces autofluorescence, which gives the detailed tissue image. So it identifies the sperm with the tubules and improves the sperm retrieval rate, and it decreases the operative time. Next. Raman spectroscopy, it's a laser beamed optics to determine the biochemical structure of a living tissue. It's a non-destructive and the sperm can be used for the ICSI. We have another technique that is the full field optical coherence tomography. It's a white light which interferes microscopy to produce high resolution image of unstained tissue, and it reduces the number of biopsies and the operative time. But it has a problem in inability to identify the nuclear and the cellular debris. And another technique, that is a sperm antibody detection, identify the antibody labeled sperm in seminiferous tubules using the micro TESA. Next. If we see the etiological factor for the non-obstructive azoospermia, it's a mainly primary testicular failure, either because of the genetic abnormalities like the Klinefelter and the Y chromosome microdeletion, or acquired like torsion, trauma, mumps, varicocele, exogenous factor like radio and chemotherapy, and the testicular cancer. If we see the hypogonadotrophic hypogonadism, it's a Kalaman syndrome and the Prader-Willi, and the acquired like pituitary tumor and the steroid abuse, which is very common nowadays. Testicular failure is a Y chromosome microdeletion or Klinefelter, cryptorchidism, testicular trauma or torsion, and the mostly mumps infection is to be ruled out. Next. Testes are either small or normal size, normal epididymis, but normal volume ejaculate. The pH is more than 7.2, either elevated or normal FSH or LH, a low or normal testosterone. They are non-mosaic like 47XXY, and the azoospermia factor YQ microdeletion, which is seen in about 15% of the cases. And the testicular biopsy particularly reveals hypospermatogenesis, Sertoli cell only, mixed pattern or maturation arrest. Next. So next. Hypogonadism, the particularly testes are of smaller size, small epididymis, palpable vas, but ejaculate volume is very less, that is less than 1.5. All hormonal parameters are low, like FSH, LH, testosterone, and there is a gene mutation in hypo. In the testicular biopsy, it's revealed nothing. Next. Klinefelter syndrome is common in 1 in 500 to 1,000 live births, and over 95% are azoospermic. Increased body height and the sparse secondary sexual characters, which affects the 30% individual. 47XXY is around 80 to 90% of the men, and the only 8% are having the some sperms in the ejaculate. And the surgical extraction of the sperm by the mid-puberty before starting the testosterone therapy. Next. So if we see the non-obstructive azoospermia with a normal volume, that is a fructose positive, either they are hypo, either they are having primary testicular failure, or either maybe obstructive azoospermia. So if we see the testicular long axis in a hypo, the long axis, it is more than 4.6, FSH is low. And if we see the hypergonadotrophic hypogonadism, the long axis is less than 4.6 and the FSH is high in hypergonadotrophic hypogonadism. So FSH is a very important investigation in evaluation of a male factor infertility. Next. Structural chromosomal anomalies like the Y chromosome microdeletions. There are 3 regions like the AZFA, B, and C. And the A, if it is affected, that is Sertoli cell only syndrome. If B is affected, that is a spermatogenesis arrested meiosis. C, it's the most frequent deletion. There is hypospermatogenesis and maturation arrest, but some sperms are there. So we can retrieve in cases of AZF-C mutations. Next. Small testes, all parameters are low, FSH and LHI high. Karyotype, it is recommended. Genetic studies, AZF-A and B, they are on for the donor insemination or the adoption. C, eligible for the sperm retrieval, bilateral multiple microbiopsy in cases with the micro-TSA. Sperm retrieval in 40% cases in a non-obstructive azoospermia with C, and the live birth rate after micro-TSA and ICSI, it is 20% and 40% with the donor sperm ICSI. Next. Hypo, Kalaman syndrome, pituitary dysfunction and anosmia. There is a gene mutation, FSH and LH treatment with the therapy. HCG, we can give 5,000 to 10,000 international unit twice or 3 times a week for starting the spermatogenesis. And the Prader-Willi syndrome, which is having the early onset obesity, hypogonadism, small testes, and the growth hormone deficiency in dysmorphic faces. Maybe problem at the level of hypothalamus, and there is a gene mutation on a chromosome 15q11, q13, an inactive paternal gene, which is mainly responsible for this type of event. Next. Space occupying lesion in pituitary, microadenoma or macroadenoma, prolactin secreting tumor. We usually don't investigate a male partner for the thyroid and prolactin because hypothyroidism and the hyperprolactinemia, they are reversible cause for the male factor infertility or oligoasthenospermia. So always look for the high prolactin level as well as the hypothyroidism in male partner also. Treatment with the dopamine agonist and or surgery if indicated. Next. So in the past, the management options for the azoospermia were limited and depressing. The examination of a male partner is of paramount importance. Proper history taking, especially the anabolic steroid abuse, which is common. Proper semen analysis, preferably by the andrologist before labeling a patient as an azoospermic. Identify the exact etiology with the history, examination, and the investigations. Genetic study, when indicated, to identify the microdeletion. Use of surgical sperm retrieve technique and the use of ICSI definitely improves the pregnancy rate, and the donor IUI and the adoption are still viable option in limited resources. Next. Thank you. Thank you very much for the patience hearing.
Pooja ma'am is not there. In behalf of her, she requests me to conclude. So very nice presentation, Dr. Akash. Very informative. Thank you for valuable knowledge. Thank you, Dr. Akash.
Thank you. Thank you.
So maybe any question from anyone? Korat sir, can we go for the next session?
Okay.
Dr. Jyoti, I would like to just add an input, Dr. Rekha here. Very nice presentation, Dr. Gajjar. It is ultimately, our intention should be to get the sperm as far as possible in these cases, even if it is NOA cases, like just because FSH is more or not investigating the patient, tell them immediately for donor insemination, etc. should not be the, that is a take home message. This is what I feel. And second thing is certain similarities between our female infertility and male infertility. Like where we do the tubal anastomosis, you request for the vasoepididymal anastomosis, and we think of primary testicular failure, you think of primary testicular failure, still you will search for the sperm so that he will be the genetic parent. Similarly, in case of primary ovarian failure or even secondary ovarian failure, though FSH is more, we still try to collect her eggs as much as possible, go for embryo pooling, etc. So that
another point, my personal observation, many young athletics who are doing gym, very active gymnasts, they have sperm count 0. In 1 month, I get 2 to 3 patients, young macho men like, but azoospermia. So is relation with protein shake or excessive exercise?
They use anabolic steroids.
Okay,
They
yes.
use testosterone and the nandrolone steroids, and they
steroids.
they use steroids, and particularly these steroids, they lower down the body testosterone level. Okay, and this anabolic steroids is mainly for the muscle bulking cycle, because
Yes.
I have a gym on opposite of my hospital, and every monthly, similarly like you, I get 2 to 3 gym person for their semen analysis report and for semen donation. Actually, we cannot accept those samples. But if I
Sure.
do semen analysis, I absolutely there is zero sperm, because they are young.
Exactly, I think it's a part of public awareness. We should have some lesson on it.
Yes,
For
we
public
do tell the patients as much as possible. And it is the awareness about the smoking and alcohol,
yes.
especially the smoking, and the physical activity is also equally important as part of awareness.
Yeah,
In
madam.
the-
Yeah, there is one particular incident I would like to quote. There is one chemical factory in Vapi. There are 10 small 10 by 10 size cottages are there, where the Bihari, this labor class work people, they all work in a chemical factory. Two couple came to me for 25, 26 years age. The wife AMH is in the range of 0.1 to 0.2. 25 years of age, and the husband is azoospermic. Before coming to Vapi, they around the last 1.5 to 2 years, they were normal. The wife's periods were normal and everything was normal. But after starting the work in this chemical factory, there are the 10 couples. They all are having infertility. They all are azoospermic. And the wife's AMH is less than 0.2 in almost 5 females which I have worked. So the working environment, like the work at the level of where there is a high temperature or chemical exposure, is that it has a very bad effect on the semen parameter, and it is very
Yes, I agree. I would also like to add, Dr. Bhavna, that we also have a big GIDC at Ankleshwar and Bharuch. And I agree with Dr. Akash that I also get many infertility patients, and the cause is the husband. Husband has a very severe oligospermia, I should say, or even azoospermia. And I agree with him because of the working environment. You know, they work in furnaces. So exposure to very high temperature also leads to this. I have seen plenty of cases of azoospermia, and there are an increase of late in the last 2-3 years because of these chemicals or working near the furnace. Even tight undergarments, I feel that also would be a reason to have low count, sperm count.
Can I come in with,
Can I come in? Sorry.
Yes, sir. Yes, sir. Vipul,
Can
sir.
I come in with just one question to Dr. Akash Gajjar? Akash, when will you advise karyotyping, and when will you advise Y fractionation?
When we see all the azoospermic patients should be evaluated for the karyotyping, and the FSH is high, especially.
So, if the sperm count is 0, you will advise karyotyping.
But I have to repeat the sample. If I see the 2 samples, and after centrifugation, if there is no sperm, I see the samples by myself, centrifuge the sample, no sperm in the semen, this pellet, then and then we can label, and after that we can advise the karyotyping.
Sir, can I
And
say
what
something?
about Y fractionation?
If Y
Y microdeletion, when will you
is
advise
positive,
Y microdeletion assay?
Hello?
When will you advise Y fractionation or Y
Chromosome,
microdeletion assay?
microdeletion. Ideally, it is can be advised in a cases of severe OATS also.
Yes. So that's what I was trying to drive at, that Y fractionation should be advised when the sperm count is less than 5 million. And I think karyotyping should be advised when the sperm count is for oligozoospermia less than 10. That is the latest ASRM guideline.
Okay.
And adding to this, if Y chromosome YC is present, then we should not go for PESA-TESA. If we go, then the child or offspring of this couple also having suffering from same.
Yes. We cannot use those sperms.
Yes.
We can repeat the same genetic defect in offspring.
Yes, sir.
And what about
Beautiful
cystic fibrosis
discussion.
mutation?
Which one?
Cystic fibrosis mutation.
It's not common in our setup. Cystic fibrosis gene mutation. It's more in the Western population.
Yes.
No, since we are not, it's a corollary to doctor's suggestion that you should not use those sperms. In cystic fibrosis, you may get an occasional sperm, but you should not be using that sperm for ICSI.
Yes.
So, Dr. Akash, take-home points from my side would be, one is get the sperm from that man as much as possible. Of course, ruling out the chromosomal abnormalities, etc. The second thing is the physical examination of the male should never be ignored. We being as obstetrician gynecologist, and third, whoever is the support there, tell them to examine, especially the size of the testis, so many things, the clinically varicocele, etc. And third thing is the equally important, along with the examination, is the education of the couple, as you said, including the occupational hazard, etc. So that we can prevent many of the things. Thank you.
Thank you. Thank you, Dr. Akash. And thank you, Dr. Vipul Kapadia ji and Dr. Ravindra Korat and Rekha madam and Dr. Bhavna madam for the nice inputs. And I am moving to the second session of today. It is the fertility enhancing surgery in endometriosis by Dr. Sejal Naik. For this, I am inviting Dr. Nupur Chasatia ma'am. Nupur ma'am is a consultant at Spring Fertility and Women's Clinic, Surat. For this, the second, Nupur madam did MBBS from GMC Gujarat and MD from PSMC Karamsad. She is DNB obstetrics and gynecology and fellowship in obstetric ultrasound medicine from Mediscan Chennai and ART training from the Cleveland Clinic, USA. And she is ICOG reproductive medicine fellowship. She did the ICOG reproductive medicine fellowship from Pune. Welcome, Nupur ma'am. Our second chairperson is Dr. Neetal Patel madam. She is president Valsad OBGYN Society and she is MBBS from BJ Medical College Ahmedabad and MS from the NHLM Medical College Ahmedabad. She has had infertility and IVF training from Kidney Hospital IKD RC Ahmedabad and diploma in laparoscopy from France in 2011. She is consultant gynecologist and IVF specialist in Sri Sainath Multi-Speciality Hospital and Test Tube Baby Center, Dharampur, Valsad. Welcome, Nital madam. Our third chairperson is Dr. Manpreet Patel madam. She is consultant OBGYN specialist in the Ashirwad Hospital, Vapi, and ICOG fellow in reproductive medicine. FMAS past secretary and joint secretary Vapi OBGYN Society, and she is Dhira master trainer. We welcome you all three chairpersons. And I request Dr. Nupur madam to give introduction of our respected speaker, Dr. Sejal Naik madam. And I request Dr. Neetal Patel madam to open the topic and Dr. Manpreet madam to conclude this topic. So I am handing over the mic to Nupur ma'am. Welcome, Nupur ma'am.
Thank you, Dr. Jyoti ma'am. I thank Dr. MC Patel sir and organizers for including me in this webinar. It's my real pleasure to introduce my senior and a very good friend, Dr. Sejal Naik. Dr. Sejal Naik, she is MS Gold Medalist with Fellowship in Minimal Access Surgery and Fellowship in Reproductive Medicine. She is a chief consultant and she owns her own hospital, Belly and Love, where she runs IAG and Foxy recognized training courses for gynec endoscopy. She has many awards to her credit, like a GEM Member Award, IAG, SOGS Appreciation Award, Best Paper Award from All India Congress in 2019, Foxy Young Star Achiever Award, and SOGS Star Award. She is a managing committee member of IAG since 2018. She is the first gynecologist to perform single incision laparoscopic hysterectomy in Gujarat. She is our past SOGS secretary in year 2018-19. She successfully organized a National Yuva IAG conference in 2019. She has published many papers in national and international journals, as well as she was invited as operating faculty in various state and national level conferences. Over to you, Dr. Sejal.
Thank you very much, dear Nupur, for kind introduction. I would like to share my screen. Please allow me to share. Yeah. So at the outset, I would like to thank Dr. MC Patel, sir, and the entire team of Happy Learning. It's been really indeed pleasure to be here. Since Corona time, sir has started so many interactive webinars, and I've already been part of many of them. So thank you so much, sir. So today's my topic is the fertility enhancing surgeries for endometriosis. As we all know, endometriosis is an enigma, and today we'll be discussing only the fertility issues related to the endometriosis. And of course, this surgery means the laparoscopy surgery. We have moved far beyond the controversies between the laparoscopy, advantages of laparoscopy over laparotomy. The clinical features, apart from the infertility, patient may present with the pain, that may be dysmenorrhea, deep-seated pelvic pain, dyspareunia, dysgeusia, etc., or maybe the abnormal bleeding, or there may be the other GI symptoms. The common sites for the endometriotic implants are most commonly the ovaries, the cul-de-sac, and the uterosacrum. The theories we all know for the endometriosis deposit, that may be the metaplasia, or the retrograde menstruation, there may be dissemination via lymphatics or blood, maybe the immunological dysfunction, or the surgical dissemination. So I'm not going so deep into such a theory topics. So now endometriosis is that affects almost 10 to 15% of the reproductive age group women, and the most of the women with endometriosis have delay in the diagnosis, of average of about 7 years from the onset of symptoms till the diagnosis. The defined cause effect relationship between the endometriosis and the infertility is still a controversial, but the prevalence of endometriosis is about 25 to 50% in the women with the infertility. And among those who have the endometriosis, out of them 30 to 50% will end up in the infertility. So it's a huge volume of burden over the fertility clinics. The fecundability rate also reduces from 15 to 20% to 2 to 10% if this endometriosis is untreated. Now, treatment is always a dilemma with the easily available, accessible, and the nowadays very cheap ART treatment. The role of laparoscopy is always a controversial. So treatment lies between the first laparoscopy or the ART, or if ART fails, then what? So let us discuss few points here. The endometriosis fertility index is the objective way of predicting the percentage of estimate the percentage of pregnancy. It includes the laparoscopic finding, that is on both sides of tubes and fimbria and ovary, whether they are normal, mildly dysfunction, or the severe dysfunction. The objective number scores is given to each. The other factors like age, the years of infertility, prior pregnancy, or these are given the other scoring numbers, and ultimately they are calculated as an EFI score. The more higher the score, there is a higher chances of getting pregnancy. And you can see there is a maximum highest chances within 1 or 1.5 years of following the surgery in each of the cases. So then it has also been recommended that if the monthly fecundability is more than 3%, then the one can attempt for non-ART conception for at least 1 year. If it is very low, less than 1%, then one has to refer for IVF immediately. Now, what are the aims for doing the laparoscopic surgery in endometriosis? One is to conserve the reproductive function, to minimize the damage, the maximum restoration of the anatomy, and the maximum removal of the disease to reduce the risk of recurrence, at the same time with minimalizing the complication risk of and increase the morbidity related to complications. We can do either the excision of the endometrioma. What are the different procedures we can offer to the lady? That we can, if there is endometrioma, we can do the excision. There may be the adhesiolysis and restoration of the anatomy. the clearance of the pouch of Douglas. There may be, we can do the excision of the endometriotic nodules or the implants over the uterus and the uterosacral ligaments, or then with the coagulation of the endometriotic nodules. Then the pain management of different techniques. And if there is a colorectal involvement, there is a different sort of debate of, between these shaving or discoid resection or the segmental resection. Bladder endometriosis, if it is present, then has to be dealt separately, and the same with the ureteroendometriosis, maybe ureterolysis, excision, stenting, or the anastomosis as per the case. So one has to follow the surgical principles here very strictly, especially in case of the endometriosis, where the preoperative assessment and the counseling by surgeon himself is very important to confirm the diagnosis, to explain the patient, take the written and informed consent, the extensiveness of the disease and the post-operative recovery phase, followed by the what she can expect following the surgery. One has also need to explain before performing the surgery to the patient that she has to enroll herself for the fertility treatment immediately following the surgery. She should not waste much more time behind wandering here and there following the laparoscopic surgery, because we have already seen there is a golden period of 6 to 12 months where she should conceive, which can give the best outcome. The discipline in the surgeon not to do overzealous correction or not to undercorrect the disease and leave the major part of the disease behind. So one has to be very good, excellent laparoscopic surgeon to perform this endometriosis surgery. The excellent knowledge about the anatomy, because anatomy usually are completely distorted and the POD is usually completely obliterated in majority of the cases. The knowledge about the equipments and their malfunctions, we need to limit the equipments. We can't have the whole sort of the sets, everything in the OT to overcrowd it. And the same with the instrument, limit the instruments to avoid the overcrowding on the patient. One can't just work like Arjun here, just to have the bird's eye. We will have to work here as a beam. We have to orient it in operation theater, your assistant, everything, equipment, instrument, patient's desire, patient's profile, and that everything accounts here for the good outcome of the surgery. Thorough examination of the uterus, adnexa, pelvis before you encounter any steps of surgery, that is a primary inspection, reconfirmation of the preoperative diagnosis, and identification of the primary landmark. What we can expect in laparoscopy, there may be a variety of lesions, that dark black lesion to white, opacified red lesion, there may be sub-ovarian or intra-ovarian cysts, there may be yellow-brown patches, and it has been noticed that even 13 to 15% of the macroscopically normal peritoneal biopsies have encountered with the endometriosis implants. So ASRM and AFS suggested that stage 1 and 2 endometriosis, always you have to perform the laparoscopic operative procedures that increases the outcome by the ongoing pregnancy rate compared to the expectant management. Now, endometrioma, well, mild to moderate cases of endometriosis, where endometrioma affects almost 17 to 44% of the women, and 50% of the cases are the bilateral endometriomas. What are the surgery can be performed on endometriomas? That can be we can just aspirate the cyst and leave it alone. That causes a very high recurrence chances. Then one can do the drainage and the ablation of the cyst wall by either laser vaporization or electrocoagulation or the sclerotherapy. You can just instill the 98% of the ethylene alcohol and leave it. That can cause the sclerosis of the cyst wall. And the other is the excision of the cyst capsule, that is the cystectomy. Cystectomy is currently considered the standard therapy. It reduces the pain, it reduces the recurrence rate, and also increases the spontaneous conception rate by 50%. Now, anatomical orientation as soon as you enter inside the abdomen is important. Just do not puncture as soon as you see the cyst. Find out all the areas around. Find out the anterior abdominal wall where the rudimentary umbilical arteries. Then go to the laterally towards the round ligament. try to stretch the round ligament up to the cornu, and try to find out the uterus if fundus is visible, and then the tube, try to trace the tube. So this is the full bladder which appeared as the cyst, and do not puncture it, that is only the K90 relieve this cyst. So cyst was below the inside the POD. So now this is also a case of severe endometriosis where densely adherent organs, you can have to trace the ureter here, starting from the pelvic brim inside, from the infundibulopelvic ligament, ovarian ligament. You can see the ureter abutting here into the endometriotic large cyst. So this will make you clear about the orientation and where the safety boundaries. So after the anatomical landmark is identified, you have to correct the adhesions first before entering into the cystectomy. Large cysts, eventually they rupture while doing the adhesiolysis. So salpingo-ovariolysis is done gently, the tubes are separated, and the ovary has to be lifted from the ovarian fossa very carefully. If it is a virgin case, no previous surgery, can use the blunt dissection like this here. But in cases of previous surgery, one has to do the sharp dissection. Once this is done, we start doing the cystectomy, where the two planes are freshly sharp cut, and two planes of endometriotic cyst and the ovary has been made here. This proper cleavage plane is important. In endometriotic cysts are usually very densely adherent, the difficult plane to find out. There's a 3 instrument working here, one atraumatic grasper holding the ovary, traumatic grasper holding the ovarian cyst, and the central ones gently pulling the cyst wall with the minimal damage to the residual ovarian tissue and with the maximum removal of the disease. So one can do the hemostasis with such a long blade bowel grasper by compressing it mechanically and keep it compressed for the 5 minutes. However, the thin area it look like, but they still contain a good amount of eggs in it. So try to preserve as far as possible. Overzealous use of the coagulation cautery current is here not recommended. Only the bleeder spots one has to control it with the electrocoagulation bipolar current. So we can invert the cyst wall inside out, then use the irrigation fluid to pinpoint the bleeding spot, then coagulate only those bleeding spot and leave the rest of the area vascular. This will reduces the damage to the stroma and the blood supply to the ovary. And then you can just invert back the ovary to the outer surface to the normal position like this, and then can use the mechanical compression for the little bit of oozing, and keep it that compressed for the clock count of 5 minutes, and majority of the bleeding is stopped. So this is the final picture. After correcting the all anatomy, removing the cyst wall, maintaining the hemostasis, one can do the superficial coagulation of the endometriotic implant, and can remove the whatever the scar material or the endometriotic implant. You can excise also. One has to be very sure about the inadvertent injuries to the vital organs, can do cystoscopy, or in a difficult bowel dissection, one can inflate the gas into the rectum, and under the water air leak can be identified and can rest assured for any injury. So endometrioma has proven its role since long, and many observational studies says it is a good outcome, 30 to 67% in 1 year after the surgery. But still, recently the role of this excision has been challenged by the many other studies, and that is on the negative effect of it on the post-operative ovarian reserve. If we remove the disease completely by cystectomy, there is a very less recurrence chance. At the same time, if we don't do the cystectomy and we just fulgurate the endometrial cyst wall, then there is a high recurrence charge, but still the preservation of the ovarian tissue is estimated to be high. So many studies have been come since then. The randomized control trial says the stripping of the cyst is comparable with the bipolar coagulation in patients' benefit and clinical outcome. but the decision has to be taken according to the recurrence of the like if it is a repeat surgery or so. AFS and ASRM suggested that they 3 and 4 grade endometriosis, one has to consider the surgery. It is a level B evidence that increases the spontaneous pregnancy rate. An infertile woman with the endometrioma undergoing surgery, clinician should perform the excision of the endometrioma capsule that has increased the spontaneous pregnancy rate. The same with the Cochrane study that says the mild and moderate endometriosis that reduces the pain and increases the live birth. The surgery for excision and ablation were similarly effective in relieving pain, although there was a very little study. In moderate and severe endometriosis, where bilateral endometriosis, that is definitely that reduces the antral follicle count, ovarian volume, and statistically significantly that reduces the IVF responses to the stimulation. So cystectomy, however, even though performed with accurate surgical technique, that leads to significant ovarian tissue removal, and that depends upon the cyst diameter. The larger the cyst, the more the tissue is removed. Minimal invasive gynecology journal has suggested that beside from the endometriosis itself, the overall quality of surgery, over the how well the surgery has been performed, as a major determining factor of the damage of the surgery ovary. Particularly attention is given on the correct plane of dissection and the judicious use of electrosurgery. It has also, they have also mentioned, if the surgery is performed by the resident or the training doctor, it causes much more damage than compared when with the experts endoscopic surgery for the endometriosis surgery. So in a nutshell, Fertilal Sterility in 2012 came up with the cystectomy definitely have the favor in the surgical approach because the benefits are many. However, the recurrent endometriosis or the patients with the decreased ovarian reserve, one has to think twice and discuss thoroughly regarding the repeat surgery for the same patient. And the other modality one can think over. So same here, the recurrent surgery endometriosis, it is like those with the recurrence of the disease is a chronic inflammatory process. So how you rate the recurrence, it all depends 6 to 67% recurrence rate. That is because what are the criteria is taken for as a consideration for the labeling as a recurrence. So it has been reported that pain appears earlier and fast, severe in a patients, in a majority of the patients compared to the clinical appearance of the disease. Sorry. Okay. So in recurrence, 2 years recurrence rate in for like stage 1 or stage 2 endometriosis is 5.7%, right? The advanced disease have the higher recurrence days. One has to be careful by introducing in your telescope inside primarily because it's a previously done surgery. One can use the Palmer's point or the under vision entry to avoid any injury while doing the entry because you can expect many adhesions. Apart from that, the deep endometriosis, where the nodule is there, some studies suggested there is a pregnancy rate are almost similar, whether you remove those deep nodules or you manage them expectantly in 24 months. Another recent study of 140 and 1 ICSI cycles, they says the female age, serum AMH level, and other previous attempts of IVF, that they also have the significant prediction for the clinical pregnancy rate apart from deep infiltrative endometriosis. But the pregnancy rate as per the patient with IVF ICSI is with those with deep infiltrative endometriosis is always lesser compared to those who don't have the deep infiltrative endometriosis. So in bowel endometriosis, it's I'd say the negative effect on reproductive outcome, and complete resection may give the better postoperative fertility results, but at the cost of increased morbidity and delay in the fertility treatment. So one has to give cautions with the radical such a surgery, especially in the asymptomatic patient. Asymptomatic means apart from infertility if there is no other symptoms. Here the stage 3 and 4 grade 4 endometriosis, where the all anatomy is disturbed. Once I lost the, yeah. So one has to do the first bowel and augmented adhesive lysis. Eventually, the such a cyst usually rupture. Here we use the scissors, most preferably, less of the energy sources, because they all vital structures are very close to each other. You won't find out the even uterine fundus here. The bowel, small bowel loop is being dissected from the lateral pelvic wall, and the hood over the bowel hood over the chocolate cyst of the left side bilateral cyst, and the uterus is being resected with the sharp dissection, because the tubes and ovaries all are buried behind this mass. Uterus is completely retroflexed and fixed. We do the sigmoidorectal resection with the sharp scissors, and you can see there is a very difficult cleavage plane here. One can use the uterine manipulator or the bowel retractor to get the good mobilization from below. So these patients are directly advised for the IVF. You can find out the unusual endometriosis like bladder endometriosis on cystoscopy. One has to do the resection and the closure of the bladder wall. Here is the case of long-lasting endometriosis with adenomyosis, where the this cyst wall has become so thick and it has been calcified like a shell of any egg or so, and that is impossible to remove such a thick, hard cyst wall from the primary trocar. So we used to use the morcellator for this. Is there any role of IUI in infertility related to endometriosis? Very limited. Stage 1 or stage 2 endometriosis may conceive with the expectant management or the minimum guidance. But the studies have very poor correlations have found with one may perform IUI with the control ovarian stimulation, which can give better results compared to the only superovulation and the time intercourse, and also better result than the natural cycle IUI. So one may opt for a few cycles of IUI in stage 1 or 2 endometriosis, but no to stage 4 endometriosis. Is there any role of surgery in those who are going for the IVF directly? If it is a unilateral endometrioma, usually it doesn't interfere with the ovarian response. If it is a hydrosalpinx, it is associated with poor pregnancy rate, so better she goes for the IVF directly. If she is less than 35 years, younger women, then one may wait for the period of like a year and opt for the other treatments. And if she is more than 35 years, should go directly for the IVF as early, like waiting period should be less than 6 months. The early IVF can give better results than the late. So it has been said that the couple are undergoing for the IVF, if the endometrium is less than 3 centimeters, no evidence suggests for the cystectomy. One can directly opt for the ovarian stimulation. But the endometrioma, those are more than 4 centimeters, larger endometrioma, or associated with pain, or it interferes with the oocyte retrieval, and the potential of having a pelvic infection while retrieval or puncturing the endometrial cyst, and the contamination of the follicular fluid. Because of such a fear, one may go for surgery for those patients, or if it is not hindering, can directly go with the IVF. Now, the fertility preservation technology is not only addresses to the surgery or IVF, it can also includes the oocytes or embryonic freezing or in the cryotissue preservation before, like if she is unmarried, or if she is opting for the medical management. So in nutshell, if the patient's age is young and no other comorbid or no other contributing factors for her fertility, then one can go with the expectant management of few cycles with superovulation or the IUI can do with a and laparoscopy. If that fails, then if that is corrected well and she is the mild to moderate cases, can go with the IUI for 1 or 2 or 3 cycles. And if she is not pregnant within this 6 to 12 month cycle, better to refer her for IVF. If she is older patient, then directly she is advised for the IVF. If she has a large endometrioma or the painful endometrioma need to be removed, then only the laparoscopy before IVF. So I would do this endometriality scoring system that correlates the disease severity with prognosis in terms of reproductive outcomes. Biomarkers like CA125, etc., has no role in diagnosis of endometriosis. Medical management should not be given in the patient trying for conception. Rather, she should immediately try for conception following the surgery, except that downregulation is being given for the ovary prior to the IVF. Laparoscopy surgery for mild and minimal cases are almost that doubles the spontaneous pregnancy rate. So one must be positive about it. In women with the moderate to severe endometriosis, operative laparoscopy increases the spontaneous pregnancy rate. But if the size of the endometrioma is larger than 4 centimeters, then the pregnancy rate and that decreases the recurrence rate. But it also negatively impacts the ovarian reserve, as marked as the AMH. Surgery in expert hand might result in significant improvement of pregnancy rate. The decrease in AMH may recover in some patients after 1 year of surgery. And the endometrioma, those who are less than 3 centimeters, need not to be removed surgically if she is not in pain. If more than 3 centimeters and patient plan for IVF, then are removed only if it is associated with pain or difficulty in assessing the follicle, etc. And the AFA, antral follicle count, is not significantly affected after excision. So IUI has the limited role in minimal or mild endometriosis, and obviously we would not like to waste the time in severe endometriosis patient. The place of IUI is limited here, especially in older women too. So repeat surgery, one has to be very cautious with the infertile couple, where if it is associated with significantly lower the pregnancy rate, better she opt for the IVF early. In patients who have failed primary surgery, assisted reproduction appears to be significantly more effective than repeat surgery. In patients who have failed assisted reproduction, the management remains extremely controversial. Now what next? The incidence of recurrence of endometriosis is not increased after the IVF. And here I would have to emphasize on the teamwork and do dream work. You need to have the very good team to have the very best outcome in the laparoscopic surgery. Thank you.
Ma'am, I have one question.
Hello,
ma'am. Ma'am, I have one question. I have one patient. She is 36 years old and she has history of severe dysmenorrhea with on-off pelvic pain throughout month and with previous 2 CS. Actually, patient not related to fertility, actually related to endometriosis. And so I gave 3 doses of injection lupragon acetate, 3.75 milligram. And after 3 doses completed, pain almost 50 to 60% pain is relieved, but not completely relieved. Actually, she does not want to hysterectomy. So what can I do?
See,
she diagnosed as a scar endometriosis, ma'am. She diagnosed as a scar endometriosis. Sorry.
A scar endometriosis doesn't require hysterectomy. You can just simply excise the scar.
Okay, ma'am.
And that is depending upon while excision of the scar, you have to be careful removing the disease-free margins, right? Okay. If it is a big scar, you may need to put the mesh to cover up the wide gap in rectus sheath. But otherwise, scar endometriosis is very well treated with the surgery. Medical management for endometriosis other than scar endometriosis, there is a role where you can pull on till the age of hysterectomy. Right. You can, Leupride is very limited, like 3 months only you can give. And it has a good amount of osteoporosis and other bone loss changes. So better I would prefer to go with the this 4th generation pills or the Dynogest or etc. So which she can take it for months together. And ultimately, if she doesn't bleed or if she enters into the menopause, the disease is cured. So our aim to give her these pseudo menopause till the time of her actual menopause. You can just delay or postpone her surgery. You can also try to put LNG IUD in these cases if it is a milder form of pain. But if it is an adenomatic uterus and the very very posteriorly stuck uterus, there are so many adhesions formation, LNG IUD may not give the optimum pain-free period. So you can try though. So OC pills, then LNG IUD, then you can try all sort of hormonal, but I would preferably won't give Leupride for these patients.
Okay.
And
Thank
then
you.
ultimately is the surgery if she.
Yeah. Thank you, ma'am.
Yes, sir, Vipul sir.
Dr. Sejal, I have one
Dr.
question.
Thank you, Dr. Sejal, for the lucid talk. I'll request other chairperson to conclude this session.
Vipul sir would like to say something.
No, I just wanted to
Yeah,
say
Vipul sir
that
wants to say.
hysterectomy is not the treatment for endometriosis. You have to remove estrogen. And for that, oophorectomy, bilateral, is the final treatment. By doing hysterectomy, you are not curing endometriosis.
Yes, sir, but at least pain is relieved.
Yes,
Following
but
hysterectomy,
endometriosis
pain
will
is
go on.
relieved.
I was talking about the scar endometriosis.
Scar endometriosis, yes.
Yeah. So, scar endometriosis, the local excision is sufficient.
Yes.
Sandhya madam, you have muted yourself.
Mute madam, Sandhya madam.
Yeah, I think the scar excision is the final answer. But to create a pseudomenopause, when doctor said the question who asked, she said that she is not interested in fertility. Probably scar excision, putting Mirena and simultaneous Dynogest for 3 months continuously might give a good result. Probably.
Yes.
Okay, thank you.
Because even oophorectomy can also lead to osteoporosis little earlier. And our women are not that particular in taking care of their bones in spite of counseling in our OPDs.
Yes, ma'am. So I'd like to know, I would like to input from Dr. Manpreet Patel regarding the talk.
Pardon?
Are they here? Dr. Neetal Patel? Dr. Manpreet? Dr. Sejal, it was really a wonderful talk. As an eye-opener. I loved everything, all the videos and the way you have presented, when to do IUI, when to go for IVF. Everything was very, very nice.
Thank
Very
you.
informative, very lucid presentation. So with this, we move on to the third session. And for this, I invite Dr. Kalpana. Over to you.
Thank you, Dr. Suman. With an interesting videos on fertility enhancing surgery, we move on to the next interesting topic, negligence in ART practice. So it is by our program director, MC Patel sir, who is a medical legal expert basically and past vice president, who is there to help each and every gynecologist in case of emergency. He always gives his visiting card to keep his visiting card under our pillows to have a very good sleep. So for this interesting session, I invite the chairperson, Dr. Mithali Thakur, Secretary, Valsad Uji Society, and Jagrati Desai, past President, Surat Uji Society, and Dr. Sandhya ma'am, past President, Surat Uji Society. Do we have their profiles? It's my pleasure to invite Dr. Mithali Thakur, who is a consultant obstetrician and gynecologist in Valsad. Madam has done diploma and fellowship in minimally invasive surgery in Delhi, co-author of rare case report on femoral facial syndrome in Indian Journal of Perinatology. Madam's interest is infertility and high-risk pregnancy. Welcome, ma'am. Our next chairperson is Dr. Jagrati Yogesh Kumar Desai, ma'am, who has got a long CV, private practitioner since 1985, President Udna Medical Association, President Surat Uji Society.
Madam, it's okay. Madam, you can continue.
I'll just summarize all your credentials. She has been trained in laparoscopy, ultrasound, colposcopy, and she has organized various conferences, member of Practical Obstetric Committee, and trainer of various program FOGSI initiative, and received various awards, Best Society Award, and many. Welcome, ma'am. Our next chairperson is Dr. Sandhya Praful Chashatia, ma'am, who is a private practitioner in Surat from almost 1987, such a senior person, life member of various organizations, President Surat Uji Society 10 to 11, past President of Perinatology Forum, Surat, member of Reproductive Endocrinology Committee 12 to 13, presented papers, and Madam is a fellow of ICUG also. Welcome, ma'am. Over to you, chairpersons. Dr. Mithal, ma'am, you can invite and introduce the speaker. Jagrati, ma'am, you can give an intro about the topic, and Sandhya, ma'am, can give concluding remarks after sister. Can we have MC sir's profile? Chairpersons?
Dr. Mithali? She's not there?
You can take over, ma'am.
Okay. At the outset, I'm very much thankful to Dr. MC Patel, sir, for giving me this opportunity at this wonderful webinar. He's a medical legal counselor, a consultant obstetrician and gynecologist, and have helped lots of people of our FOGSI fraternity. He has been the organizing secretary of AICOG in 2017. He was a vice president of FOGSI in 2018, chairperson of the Ethics and the Medical Legal Committee, FOGSI 2011 to 13. He has organized many conferences. He has been the national president of National Medicals Organization in 1618. He was the president of IMA Ahmedabad branch in 2007 and 8. He has been the honorary surgeon, Indian Red Cross Eye Bank, and an organizing chairperson, Vivekanand NMOCon in 2013.
It will do, Jagrati. You can have opening remarks for the subject, and straightway we can come to the subject.
Yeah, in India, we know that the government has notified the Surrogacy Act and the Assisted Reproductive Act 2021, which proposes the establishment of a national registry and registration authority for all the clinics and medical professionals practicing in this field. The ART bill or the act, as it seeks to regulate and supervise the ART clinics, the ART banks, and to prevent misuse, adopt safe and ethical practice, and so on. But lately we have been seeing that the medical malpractice cases and the claims in relation to ART has also been on a rise. So today, we have a highly knowledgeable and a medical legal counselor, Dr. MC Patel sir, who will enlighten us and update us with all the latest things about what constitutes negligence in ART. So the stage is all yours, Dr. MC Patel sir, and everyone is very much eager to hear you. Welcome,
you.
sir.
Thank you. Thank you very much, Jagruti Ben, for kind words and remarks for the subject. So greetings from Statue of Unity and tallest statue of world, and we all are proud of that statue. What constitutes negligence in ART practice is the subject for discussion. Warm welcome all the delegates and wishing you a litigation-free practice. At the outset, I would like to thank all the societies who have joined this webinar: Vapi, Valsad, Navsari, Surat, and Bharuch, and President and Secretary of respective society, and all the delegates. Usually I start any of my talk with this question: is it worth discussing? Yes. And if it is yes, then why? Because medical litigations are increasing in number constantly and steadily, rightly mentioned by Dr. Jagruti Ben. And unluckily, we gynecologists rank first, whether we are practicing obstetrics or whether we are practicing gynecology or in this era of ART practice also. And as far as criminal litigation is concerned, it is a major threat above and over civil litigation and litigation under CPA. Because nowadays, patient or patient party may prefer to go for simultaneous litigation under CPA for compensation, and criminal litigation in medical council, in government, in human rights commission. So there are so many issues in this type of situation. So let us first understand what is negligence. So in our curriculum, forensic medicine, we were taught two words: omission and commission. So act of omission means not to do something which a reasonable, prudent doctor would do. Say, for example, giving full dose of penicillin without a test dose is an act of omission and it constitutes negligence. What is the act of commission? Means doing something which a reasonable, prudent doctor would not do. Say, if you are going to plan surgery and patient has come up with full stomach, and if you are going for surgery, then it is an act of commission, because usually if it is a planned surgery, prudent doctor would not go for surgery in this type of situation. So with understanding this act of omission and act of commission, let us see, as far as negligence is concerned, it is a breach of legal duty or care owed to the patient by doctor, whereby patient suffers damage, whether it could be physical, psychological, or financial. So what is the breach of legal duty? So there are four ingredients of negligence, and first is existence of legal duty. So what is legal duty? As soon as you accept any patient to treat, it becomes a contract or implied contract between patient and yourself, and your legal duty starts from that point of time. So it is a contract or implied contract. You are offering your expert services and patient pays for that, or patient promises to pay for that. So it is a contract for personal services. So legal duty stems from acceptance of duty in a legal way. Breach of that duty. If there is a breach of that duty in any means, either carelessness, negligence, or whatever it may be, then it becomes a breach of duty. And damage suffered by patient. Due to breach of your legal duty, if patient has suffered some damage. And very important issue is doctor's conduct is direct and proximate cause of such damage. So if one fulfills all those four ingredients, existence of legal duty, breach of that duty, damage suffered by patient, doctor's conduct is direct and proximate cause of such damage, then it becomes a negligence. So it could be civil or it could be criminal. In civil, they go for compensation or claim, and in criminal cases, If it is proved, then there could be provision of imprisonment also. So there are some situations you may end up into litigation, and which are the common allegations in our day-to-day practice and in practice of ART also. Delayed in diagnosis, investigation or treatment, misdiagnosis, investigation or treatment, wrong diagnosis, unnecessary investigations, no proper consent, staff not qualified, infrastructure issue, emergency services not rendered properly, communication failure, delayed in transfer, in need of time when we have to refer patient to higher center, and if it is delayed, then it could be also one of the allegation. Complications during our ART treatment, say for example OHSS or multiple gestations, in case of fetal reduction in multiple gestation, possibility of infection, possibility of hemorrhage, injury to surrounding structure during our any surgery related to infertility, nicely covered by Dr. Sejal in previous lecture. So in all these cases of complication, they are potential area for litigation. Morbidity, maternal and fetal after pregnancy, if at all there is morbidity on part of maternal side or fetal side, it could be one more area for litigation. And in few of the cases, mortality, either maternal or fetal, is also one of the area. Overcharging is one very common allegation nowadays, because tremendous expense against unexpected result is one of the area for litigation. Ask for medical record and not provided. If patient has asked for record, and if you have not provided, then also it becomes a one area for litigation. And you are under obligation to provide record to the patient and patient party within 72 hours as per MCI guideline, and with newer guideline from NMC, within 5 working days, you are under obligation to provide record to the patient. Failure of patient to comply with scheduled follow-up. Many times patient doesn't come for follow-up and she suffers from something, then it becomes a contributory negligence on part of patient. It is a good defense in your favor, but it is also one of the area for litigation. And many times whenever you are facing litigation related to any ART treatment, not anticipated or not prepared to manage is a very important area for litigation. Say for example, in an ovarian stimulation, and if at all it is ended into OHSS, then in court of law, this will be asked, what was it preventable? And usually you cannot say it was not preventable. One more question will come. If it is yes, if it was preventable, then what did you do to prevent it? And why you couldn't prevent it? Because many a time, in spite of your care and caution, you cannot prevent certain complications. Then this question can come, why you couldn't prevent it? And if at all you couldn't prevent it, then did you diagnose that complication related to ART treatment in time? And very important question, did you manage way in which any prudent doctor would have managed? So if you can answer all those questions, then you could be out of problem in this type of situation. Let us see few of the cases decided in different courts related to ART treatment. In this famous case of Kalyan Test Tube Baby Center, it was misleading advertisement in the camp that no result, no money. And patient was investigated and treated. Rupees 90,000 were collected, but later on endometrium was not good. So embryo transfer was not done and cycle was cancelled. So, and they deduct the amount of expense incurred for stimulation and pick up, and case was filed. So inference held by the court in this particular case was, though the center must have incurred cost in stimulation and pickup, but since it was promised, it has to be refunded. So it was judgment in this particular case. So if you promise to give money back, then you are under obligation to give money back. So many a times, money back if cycle fails, is it ethical? Many times it is advertisement on part of our treating doctor. So advertisement like this, if first cycle fails, second cycle will be free. Is it ethical as per the norms of NMC? Can they suspend license due to this reason only? Is any legal issue? Can one give guarantee? So as far as guarantee is concerned, you cannot give guarantee of result, because once you have given guarantee of result, and we know as far as any ART treatment is concerned, 100% guarantee is not sure. So you cannot give guarantee. But as far as money back guarantee is concerned, you are not giving guarantee for result. You are giving guarantee that if cycle fails, second cycle will be free, or if patient opt to quit, then money should be transferred. So it doesn't matter as far as legal issue is concerned, because you are not giving guarantee for result. Many times this is one more area. अरे यार पैसे तो gonadotropin में है, and IVF consultant sell gonadotropin for profit margin to the patient. So many a time question comes, is it allowed under pretext that I am using for my patient only? So it is a question of use versus sale of drugs under DGCI. So it is not selling. When you are using in your own patient, it is a kind of dispensing, and you can very well dispense medicine for your own patient. So doctor can legally dispense, there is no issue, but it is very clear, it should be very clear, only to his or her patient or to other doctors only. And the drugs which are in Schedule C, it can be given to the patient or can be given to other professional colleague. Cannot open shop or cannot import drugs. If one has to open shop, then they will have to go for license from drug control officers, etc. Otherwise, in ART treatment, you can very well dispense all the drugs to your patient. Have to keep record of the same. When you have dispensed the drug and you have purchased the drug, then you have to keep all the record, how much amount you purchase, with this expiry date, and in which patient you use those drugs. It should be well maintained in register. Let us see this one more very interesting case. In this case, ICSI, with sperm derived from testicular biopsy for a couple with male factor, patient was azoospermic, and patient was PCOS and multiple fibroids. So ICSI was preferred in this particular case, and after failure of 2 cycles, success was achieved in 3rd cycle, and Proginova and natural progesterone was prescribed for support. So in this particular case, allegation on part of patient was they were advised bed rest. As such, it was denied by doctor because she ended into pulmonary embolism, and allegation on part of patient was doctor advised us complete bed rest, and that led to embolic phenomena, and ultimately pulmonary embolism happened. But doctor denied that he never advised complete bed rest. So in this type of situation, we may end up into litigation. Let us see few of the very special cases as far as ART treatments are concerned. ART done and donor gametes used. Is it adultery? No. If prior consent of partners is taken, then it doesn't become adultery. AID without husband's consent. Can it be a ground for divorce or judicial separation? If patient has preferred to go for AID without husband's consent, of course it becomes a ground for divorce, because it is a breach of confidentiality between husband and wife. But in the same time, doctor may also be held responsible, because in case of AID, to proceed with the treatment without consent of husband is a crime. Say for example, one more area, AIH, pregnancy. Husband never had an intercourse willfully or because of impotency, and is it considered as a consummation of marriage? Because in case of AIH, semen sample was retrieved anyway, and it was issue related to the divorce, etc. So allegation was, is it considered as a consummation of marriage? can decree of nullity be granted in favor of wife for divorce under impotency? So in this type of situation, it is not consummated because they had never an intercourse and pregnancy happened with AIH only. So it was considered in court of law and decree of nullity was possible in this particular case. So these are certain situations in our day-to-day practice of ART. One more area, under Indian Evidence Act, child born with 280 days of dissolution of marriage, child will be considered legitimate child. But if it was born from store sperm of husband, it doesn't apply. So in other cases, child should have been born within 280 days of dissolution of marriage, then only that child will be considered legitimate. But if a stored sperm of husband is used, then this is not applied. Child is always legitimate. Let us see some situations. What happens if DNA of baby doesn't match with genetic parents? In other words, we can stamp it as a lab mix-up. What happens in this type of situation? It is a very difficult situation. Say, for example, DNA of surrogate baby doesn't match with genetic parents. So this is one more area. As far as surrogacy contract is concerned, even if baby born congenital with congenital anomaly, then also commissioning couple is under obligation to take custody of baby. But in this particular situation, when DNA of surrogate baby doesn't match with genetic parents, then is intending parent still bound to accept the baby? So these are some area in ART practice we should be very careful. So not to end up into this type of situation and to avoid lab mix-up. What should be the protocol? Can we have a barcode system? We can have a barcode system, and the same barcode sticker can be stick to the file of the patient, and with that barcode only sample of that very patient will be open for use. So if we go like this, then this type of problem we can avoid. One more interesting situation, death of an egg donor. Many a times it may happen, egg is donated, but before further procedure is done, death of egg donor happens in few of the conditions. So what is the medico-legal scenario in this type of situation? And what is the role of ART bank in such situation? So if prior consent from egg donor is properly given, that very egg can be used for recipient couple, then that very egg can be supplied to the ART clinic for that very recipient for proper use if prior consent is given. Otherwise, ART bank will allowed to perish this egg, or they can give for a research purpose also. But for that also prior consent from donor is very much required. So these are some scenario. Is it legally correct if wife without husband's knowledge request for egg donation? No, because in any ART treatment, all the party involved, consent of all the party involved is must. So without knowledge or without consent of husband, in this type of situation, we should not entertain egg donation or so. Is it legally correct to use donor sperm with only husband's consent without wife's consent or vice versa? No, just I mentioned, party involved in ART treatment, consent of all the party involved should be there. One more situation, embryo developed and before transfer, death of husband. So in this type of situation, can wife use this embryo? If prior consent is given, then yes. One more area, the same way, embryo developed and death of wife, then can husband claim that embryo for use in her friend or second wife in second marriage? So in all this situation, prior consent is very much required. If prior consent is suggestive that it can be used by husband or vice versa used by wife, then it can be used. One more area, death of both. Embryo is developed and death of both this commissioning couple. So in this situation, can father of husband claim embryo or can father of wife claim embryo? So again, prior consent should be very specific in this type of situation, what should be done. So if you have very clear in at the time of taking consent, then you have not to worry in this type of situation. So what to do and how to prevent not to end up into any kind of litigation as far as ART treatment is concerned. And it is very clear, no ART clinic or ART bank or surrogacy clinic can function without registration. And it is very much mandatory under section 15 of ART Act. And we know ART Act enacted on 25th of January, notified in Government Gazette. And it was notified that within 6 months, already running ART clinic should apply for registration. So up to 25th of July, but almost 19 states couldn't apply for registration clinics which were already running. So government came with ordinance and 3 months extension was given. So from July to October and up to 25th of October, one had to apply. So once you have applied for registration, I am talking of clinic which were running already, they can practice as they were practicing prior without waiting for registration on part of government. Because you have already applied online, you can do practice. It is very clear in ART Act also. But in few of the states, I can quote UP, Bihar and Madhya Pradesh, they have extended this limit up to March 31st. So clinic who have failed to apply, they can still apply for registration up to 31st of March. But it is very clear, no center can function without registration. And same way for surrogacy clinic also, they have to go for application. So as far as, let us see a few of the things about registration. So there are two categories, ART clinic, ART bank and surrogacy clinic also, three categories. But previously it was decided or passed in Government Gazette that one cannot run ART clinic and ART bank at the same place and management should not be the same. But government is under consideration to allow, and it is all possible that at one place ART clinic and ART bank and surrogacy clinic can function. But we are waiting for clear rules and regulation on part of government. So we should be very clear. It is also very clear there should be two level clinic. Level 1, if you are interested to do ART practice up to IUI, you have to register as a level 1. And other than IUI and above all the procedure, then level 2. But again, there is one area of, gray area, because if person do not want to go for IUI in his own clinic, can he go for consultation? Can he go for stimulation? Can he go for counseling? So it is not clear, but somebody telling who is member on national board that there was RTI, and in RTI government has specified one cannot do this unless center is registered either as a level 1 or level 2 center. But still on part of FOXI and ISAR, there is a negotiation going on with government, and whether government is pleased to allow, let us see what is the result on part of government. So not to end up into any litigation related to ART, law or any court expect from us anticipation or foreseeability about probable complication, and we should be readily available to deal with that complication with any intensive care or procedure. And if at all there is a possibility of blood transfusion, we should be ready with that also. Say for example, in a case of ovarian stimulation, we should anticipate that patient may end up into OHSS in a few of the situation, and we should be readily available to deal with the situation. So court expects from you anticipation of such kind of complication, and proper counseling is very much important. So at the time of counseling, we should explain everything in detail about success rate, about probable complication, and about all the prognosis and outcome of the procedure. No rosy picture about result, no tall claim about result. Because when you claim to be master, in eye of law, you are supposed to be master. And we know in our ART practice, we cannot give rosy picture or tall claim as far as result is concerned. We can give guarantee of our best effort, but not of result. So we should be very careful, because many times we may consider our approach and result like Aishwarya Rai, but it may turn like this anytime. So no tall claim, no rosy picture about result in ART treatment. So proper communication, and once you get signature on consent, this is a documentation, because in this famous case of C. Jaipal Reddy versus Padmini Velluri, it was very specifically mentioned by National Commission that consent is not mere piece of paper where patient or relative has to sign. It is a very important document of your counseling. Once you have counseled everything and you have entered in all the points counseled in consent paper, and patient has signed the signature, then it becomes a documentation of your communication. So it is very important thing. And once you offer all those documents in court of law, when you are facing litigation, it becomes a communication of your documentation. So records are always at your rescue. So keep them up to date. What was done, nothing was neglected, and given treatment fully met with standard demanded by law and ethics. And it should be easily acceptable whenever offered in the court, because we are bound to produce record whenever offered in the court. And there are some forms, prescribed form under ART Act, and all these forms we have to observe. Say, for example, Form 1, application form for registration of ART clinic. Form 2, application for ART bank. Form 3, certificate of registration. If your center is allowed registration, then certificate will be given in Form 3. Either it is level 1 or level 2, or it is ART bank or surrogacy clinic. Appeal against appropriate authority. If you are aggrieved with a decision of appropriate authority, you can go in appeal on higher authority. But for that also there is prescribed Form 4, and you have to go for appeal in Form 4. Form 5 is format for making complaint to grievance cell. So what is grievance cell? Under ART Act, every ART clinic should have grievance cell. So any aggrieved person may have complaint in grievance cell. So any patient, a relative of patient, or any visitor of your hospital, or any person can complain in grievance cell. So it is also very much required. So, and it is also prescribed form, that is Form 5. So any aggrieved person will complain before grievance cell in Form 5. Form 6 to be signed by couple or woman who are seeking ART treatment. If you are going to go for IUI, then consent of with husband, semen or sperm. In Form 7, you have to go for consent. If IUI with donor semen, then Form 8, freezing of embryo. Form 9, freezing of gametes or spermatocytes. Form 10. And if it is a case of minor, and if you are going to go for freezing of gamete, that is sperm or oocyte, then consent of parents is very much required. And Form 11 is the prescribed form. You have to fill that form, and you can preserve or freeze gamete or sperm of minor also. Oocyte retrieval, Form 12. Oocyte donation, that is oocyte donor, Form 13. And record of use of donor gamete. It is a table given in this very form, and Form 14A is for oocyte donor and 14B for oocyte embryo record. So how much oocyte you had from donor, how many used then for that particular patient, and how many saved. So all the records should be given in this prescribed form, that is form 14A and 14B respectively. Form 15 is concerned form for donor of sperm. So all this prescribed form available on Foxy, on a website, and it is under ART Act. But these forms are not complete in eye of Supreme Court's consent, because in famous case of Samira Kohli versus Prabha Manchanda, concept of consent in India was discussed and decided at length. What should be the ideal consent in Indian consent? So all the forms just we discussed are not complete form as far as informed consent is concerned. So you should have one separate informed consent also. You will have to go for consent in those prescribed form because it is legally mandated and required. And whenever any appropriate authority visits your hospital, they may ask for all those consent. But if at all you are facing any litigation, and if patient claims that they were not informed properly or they were not told all the criteria or all the possible complications or consequences, then you may be put into trouble. So you should have one more separate informed consent in all these procedure as far as ART treatment is concerned. And doctor is bound to produce record whenever asked by the court. And if he doesn't, then adverse inference might be drawn. And it is very obvious, good record is good defense, poor record is poor defense, and no record is no defense. And it has been my experience during my medical legal practice. Doctors are very poor as far as record keeping is concerned. So to conclude with carry home message, standard protocols you have to observe as far as ART treatment is concerned. Adequate supervision and monitoring throughout all the procedure. Communication, counseling and consent is very much required. Proper documentation and record keeping, foreseeability and anticipation, multi-speciality approach. If at all you are dealing with any complication, then always invite your professional colleague to help. It shows your consent to save life of patient. So multi-speciality approach is also very much required. Prompt diagnosis with necessary investigation in any complication, and qualified anesthesiologist in any of your procedure related to ART, and audit of your own case if you have suffered any complication or any litigation is very much required. This gentleman has so many staircases, but he doesn't know how to use them. So it doesn't matter how many resources you have. If you do not know how to use them, they will never be enough. And so have some basic legal knowledge. Always obtain medical legal advice whenever you are in doubt. So if you want to sleep like this, take tender care of your patient. Observe all the provision of ART Act. Pray our Almighty God before going to sleep, and keep my visiting card below your pillow. And this is law of leopard behind innocent gynecologist, and see the role of medical legal counselor, how he can be useful in any given situation. So please do not hesitate to have an opinion from medical legal counselor in any point of time in problem or litigation. So God bless you and have a litigation-free medical practice. With regards, salute to all the societies who have joined this webinar. Thank you very much. Please do not assume. Please ask if any query, any question, if chairpersons and time permits. Thank you very much.
Thank you very much, Dr. Patel sir. As usual, it is a really very informative. But I think looking at all these consent forms and counseling, probably all ART junior practitioners might be afraid of. It is a double-edged sword, and we are constantly under the threat of swinging that sword only on a thread. A simple thread, not a barbus of our surgeries.
But Sanjana, not to worry, if you go with all those forms just we described, and if you have your own consent, that is informed consent form, then nothing to worry. And if you have to strictly follow the provision of ART Act, that's all.
Exactly.
Hello.
Exactly. We must know, as you have already shown, that we must know little law also, which we all are very poor at it. Sir, one thing, one question I will like to take liberty to ask, except, excuse me for that, the audience, we will allow you. The only question is that how long these ART people will have to keep the records?
Yes. So
how many years?
Yes. So for 10 years, you will have to preserve all the record related to ART clinic and ART bank. And after 10 years, you will have to transfer all those records to National Registry. If you are closing your center before 10 years, then record to be transferred to National Registry. If any litigation, then till final disposal of the case or 10 years, whichever is the later. But as far as surrogacy part is concerned, you will have to preserve all the record for 25 years. And after 25 years, you can dispose of those records. You have not to transfer record to National Registry.
Oh, hello.
Yes.
Okay, thank you, sir.
Dr. MC Patel.
Excuse me,
Yeah.
Narendra
Okay.
sir.
Yeah.
And will it be a physical record or a digital will do?
Just now you are having physical record, but very soon National Registry is going to form a portal to form all the online record keeping. So at within very specified time given
Online
by
will
National
also
Registry,
be
you will have to
legit.
give all the record, information of patient online also. Say for example, if you have done embryo transfer, then that very embryo, the information you will have to transfer to National Registry within very specific time given
Even
as per
online,
rule of
huh?
ART. So it will be available online also, and portal is being ready on part of government.
Hello.
Thank you, sir. Narendra sir, please
MC
go
Patel.
ahead.
Yes.
Yeah. Embryo reduction is not MTP.
Yes.
So MTP form is not to be filled up.
Naturally.
Right? Agreed, ne?
Hmm.
So what other forms have to be filled up for embryo reduction?
So as far as embryo reduction is concerned in multiple pregnancy, it is not termination of pregnancy. Say for example, it was triplet, and if you have reduced one, still pregnancy is continued. So it is not termination of pregnancy. So provision of MTP Act doesn't apply in this condition. But as far as embryo reduction is concerned, naturally you are going to go with sonography. So here comes the role of PCP-NDT Act. So if you are naturally you are doing in an antenatal patient, so you will go for Form F, and in Form F, part A, B, C, D, and we know part A is information, part D is declaration, part B is non-invasive procedure, and part C is invasive procedure. So in this particular condition, it is invasive procedure. So we will have to go for all the part A, B, C, D as far as PCP-NDT part is concerned.
And another question.
Yes.
There is a limit for maximum number of oocytes which are to be retrieved.
Yes.
Say for example 7, I think. So what about other oocytes?
So as far as this problem is concerned, we had a long discussion with government also, and Dr. R.G. Patel is on national board, and two other members who are on a national board. We had a good discussion during ISAR conference recently concluded at Bhopal, and government is pleased to consider this, because we know the government has advised that you will go for low protocol, but can we give guarantee even with low protocol there would not be oocyte more than 7? So there was some jugglery of word only. You can retrieve all the follicle, because they have written that you cannot retrieve 7 oocyte, but follicle doesn't mean that it contains oocyte. So you can retrieve all the follicle, and you can mention that out of those follicle 7 oocytes or whichever oocyte you have received and retrieved for further use. But still discussion is going on with government to liberalize this provision, because we all know we cannot keep patient at mercy of OHSS.
Any other question?
Yeah, I had something to ask regarding continuation of Dr. Narendra Gajar's question. In Bhopal, Isar, another doctor was giving a good input. He was telling that because we have already given trigger, and if we have retrieved only 7 oocytes, with rest of the follicles that is getting ruptured, that patient can get pregnant on her own, especially if she is a donor.
Yes,
That
it
is
is
another
one more area.
problem. That is one thing I wanted to tell. So that is what Dr. Patel is telling. And Sir Patel, sir, I was not very clear in Bhopal, Isar, because the minister was coming and it was winding up very fast. I did not get the answer properly regarding the difference between what should we put our board as, like the ART center, ART clinic, or is there any difference? Does any word matter?
Categories are very much specified in ART Act. Either your center could be ART clinic or ART bank or surrogacy clinic, or 3 of them. Because but there is no any category of ART center. ART clinic, ART bank, surrogacy clinic.
Okay, fine. And another thing I wanted to ask was regarding the, what do you say, that level 1, level 2 and all that. Suppose probably you have told this, that with the Foxy we have put already the application that it should be considered and all that. If they claim that every person who is doing the follicular scan also should be considered under ART 1, even if they are not handling gametes like IUI, just scan itself, if it is, they have to be registered, then all the scan centers should get registered under level 1.
So during my talk also I specified that,
yeah, that is
counseling and to go for investigation for this infertility and ovulation stimulation can one do without registration of center is a gray area, and in that also negotiation is going on. There was RTI for that. In that RTI, government has very specifically said no. One should have a registration either as a level 1 or level 2. Then only one can counsel, one can investigate, and one can stimulate. But we are requesting government to consider without registration also one can investigate or one can counsel the patient. Because any patient comes to any ordinary gynecologist, and if they are keen to go for the baby, then can't she or he examine that patient, can't she advise that what is the problem, can't she investigate. Of course, she cannot go for any procedure unless his or her center is registered. But as far as counseling and investigation is concerned, on part of government, there should be some liberty. So on part of Foxy and ISAR, we are trying for the same. Let us hope for best.
Yeah, on the similar lines only, I meant that scan centers also have to be registered if they are just scanning the patient.
Because in that situation, any sonologist, if he referred for follicular study, then also he will have to be registered if this problem is not solved on part of government.
Probably even the laparoscopic, like Dr. Sejal, who are doing the laparoscopic ovarian drilling, they are touching the follicle, which can get extended anywhere if we are talking like that.
No, madam, it is handling of the gamete. It's not about touching the ovaries.
That is what exactly I'm saying. That is why we cannot include the scan.
But let me talk. As such, I had planned to take time of our Honorable Health Minister Gujarat. I am talking about Gujarat on Sugog platform. But due to sudden demise of mother-in-law of Dr. Kamini, we have postponed that meeting. And we are going to meet our Health Minister with some issues related to MTP Act, related to PCPNT Act, and related to ART Act. Because as far as ART Act and rules are concerned, it is a prerogative of center, but health is a state subject. So as far as regulation is concerned, how this ART Act should be regulated is a prerogative of state. And we are going to give them some inputs. What could be the problem in implementation of this act, and which are the solution for the same. So we are going to have good meeting, and let us hope that government may come up with a good favor as far as our Sugog request is concerned.
Yeah, and one more thing, sir, like this Mr. Rajendran's case, we have to mention about the bed rest, their food, fluid intake, everything we should mention.
So, as far as, but say for example, thromboembolic phenomena is not the only result of bed rest. There could be some other reason also. So, how you put your case before Honorable Court when you are facing litigation is very much important. Many a times, these are the cases, poorly fought cases in court of law. Otherwise, these cases are not to be lost.
Yeah, but should we mention, sir, like not advise bed rest?
If it is required, then we have to mention. If you have not mentioned, then also you may be in a trouble because you never advise rest for the same. But if to be on to be on safer side of if we say it a abundant caution, if we advise bed rest, we may write also possibility of thromboembolic phenomena was also explained. Then you are out of problem.
Okay, sir. Right.
Sir, can you throw light on the overseas patient coming specially for the IVF treatment?
Now with this new act, it is very difficult for overseas patient. Yes, if they are Indian citizen, then there is no problem. But if they are foreign citizens, then again we are going to discuss with government on part of FOXI and ISAR. So what should be the clarification on part of government? Because there are so many gray areas in this type of situation. But
thank you so much. I think, sir, we are running out of time, and yet whole panel discussion is left out.
So we should conclude
and this discussion is such which will never end, I think.
Oh yes, oh yes.
So I hope, sorry to interrupt, but we have to conclude the session, and I hand over.
Or if any question you can put in question box, we will try to answer.
Yeah, that's good. And hand it over to Dr. Suman.
Thank you, ma'am. After very good interaction, even the act is not very clear. So you may personally contact MC sir for your clarification.
That's
yeah, he will give you the legal issues and how to protect yourself. So now moving on to the next interesting panel discussion, sudden obstetric collapse. It's my pleasure to invite the panel moderator, Dr. Prakash Bhatt sir, who was a past president, Surat OG Society, Vice President, Federation of Obs-Gyn Societies of India, past chairperson, Rural Obstetric Committee, FOXI, received a Distinguished Community Award of Columbia University, New York, by International Federation of Obstetrician and Gynecologists, and he was the first person to receive this honor. He had executed FOXI programs, emergency obstetric care training with Johns Hopkins University, later on with government. Welcome, sir. Our next moderator is Dr. Chintan Thakur, who had worked as a superintendent CHC for 2 years, worked as gynecologist at Crest Hospital, and now into private practice, Mother Care Hospital, for the past 14 years, and government panel of laparoscopic surgeons, done community projects, many health camps, and awareness programs, presented papers in various conferences, conducted various conferences and workshops, and welcome you, sir.
Thank you, ma'am.
Our expert for the panel is Sneha Bhuya ma'am, who was the past breast committee chairperson, governing council member of ICOG, SAPOG working committee member of breastfeeding, AMOX chairperson medical disorder committee, founder president of Vidarbha Isopar, received various awards like MS Signature Award, GCC Award, SN Malhotra Individual National Award, Urusha Distinguished Community Award, Anandibai Joshi Award, and Lokmat Healthcare Excellence Award in 2020. And she has got vast experience of almost 30 years and various publications and 300 plus talks. Welcome, Sneha ma'am, as an expert and convener. And our next expert is Rekha Rajendra Kumar, who is a director of Miracle IVF Hospital and Chandana Hospital, Bangalore. And she has done various diplomas in human resources, development, health and hospital management, vice president, Bangalore Society, South Zone coordinator, Foxy Infertility Committee, chairperson, Infertility ART Committee, Kasoga, and she has got rich teaching experience, also organized various conferences, life member of various organizations, and published many papers. Welcome, Dr. Rekha, as an expert for this panel. It is to welcome all the panelists, Dr. Praful Joshi, past president, Surat OG Society, Dr. Quresha Qureshi, past president, Valsad OG Society, Dr. Jayshree Dena Kapadia, past president, Vapi OG Society, Dr. Pratichi Mawani, past secretary, Valsad OG Society, Dr. Yogini Rolke, past President, Valsad OG Society, Dr. Hiral Pandya, Secretary, Baruch OG Society, Dr. Darshan Wadekar, President, Surat OG Society, Dr. Satyan Kasabala, Secretary, Navsari OG Society, Dr. Kajal Mangukia, past Secretary of Surat OG Society. Welcome, I welcome all the panelists, and over to the moderators.
Thank you very much, ma'am. My co-moderator, Dr. Prakash sir, is there?
Yeah, very much there.
Okay. Welcome and good evening, sir. And
Shall I begin?
Sir, over to you.
Chintan, yeah.
Yes, sir.
Share the screen. Yeah. मैं अकेला ही चला था जानिब मगरिब, मगर माहिरीन साथ आते गए और कारवा बनता गया. और वो भी कैसे कैसे माहिरीन. Look at their names and you feel like saluting them. तो कारवा बन गया और हम चल पड़े किसी की तलाश में.
Sir, I think you need to share your screen first. Okay.
And then suddenly goes wrong. The tsunami strikes and this hasta hua karwa is shattered on the shore of the Sahil. And that is what is known as sudden obstetric collapse. It strikes us like this and everything is drowned in a jiffy. So let us see how it happens and what it happens. Over to you, Chintan.
Yes, sir. Thank you. Next slide, please. Okay. So we can I know who from the panelists who are present? I mean, who are with us right now? Dr. Praful Joshi sir, I can see you. Good evening and welcome.
Yeah, I'm Dr. Jayshree Jaina Kapadia from Vapi Ops and Gynec Society.
Yeah, welcome Jayshree ma'am.
I'm Dr. Hiral Pandya from Bharuch.
Okay, welcome Hiral.
I'm Dr. Quresha from Padi. Well, sir.
Welcome, ma'am. So I think we have four panelists with us, and so we can start the discussion with our first case. Before that, I would just like to can I have the the presentation on the screen, please?
Mehul?
Sir, may I share? Yeah.
Yeah,
Just-
please share at least Dr. Chintan's slides, then I will take over mine.
Dr. Pratichi is also there.
Okay, welcome, Dr. Pratichi.
Share Dr. Chintan's slide,
Okay,
not my slides. You have his slides. Chintan, have you sent it?
ના સર મેં સ્લાઇડ નથી મોકલી એમને.
Oh my goodness. Okay, then at least
That's
you'll have to
fine.
share your screen yourself. I'm sorry.
Okay, can we, this is the 5th slide. Can we go to the,
Yes, sir. You can also share slide.
okay, is it possible?
Yeah.
Okay, I'll do that.
Chintan bhai, by
Yes,
the
sir.
time your slide sharing is sorted out, shall I start with the first case? We are already.
Yes,
running
sir. Yes,
out
sir.
of
Please do that.
Okay, okay. Thank you so much. Mrs. XY, 29 years. Am I audible?
Yes, sir.
Yes, sir.
Primary gravida with a very smooth antenatal period. Karwa अच्छा चल रहा था. Routine antenatal investigations normal. Went into labor spontaneously at 38 weeks and 4 days. What more one can ask for? Progress a bit slowly, but otherwise fine. Admission CTG normal limits. Monitored according to the WHO modified partogram. Though a bit slow, labor progressed and progressed well without any signs of fetal compromise. Once the cervix got fully dilated and the membrane ruptured spontaneously, the labor accelerated. And she took around 1 hour and few minutes for her second stage to reach almost near delivery. When the head was on perineum, it was feared that she might develop perineal tears. And so the episiotomy was decided and mediolateral episiotomy was incised. And there began the troubles. No sooner the episiotomy was incised, significant bleeding from inside the vagina ensued. What can be the likely cause? Can we begin with Dr. Pratichi? Pratichi, you listen to me? No. Then can we switch over to Dr. Hiral Pandya?
Sir, likely cause can be episiotomy extension inside, which we are not able to visualize. There may be a laceration. As the cervix
Yeah.
or fully dilated, naturally we can't expect cervical tear, but because of the extension of the laceration, this bleeding can occur.
Okay. Any other opinion from any other experts?
It can be cervical tear also, angular tear in the extension in the cervical tear also, though fully stretched.
Okay. Anybody with a different opinion there?
Extension of head or sometime maybe the sudden placental separation we may think over.
Okay, so you are thinking in terms of abruptio placenta, madam? Okay, okay, that's
Sir, there
great.
can be rupture uterus.
Rupture uterus, my goodness. Okay, then?
Can it be a bleeding from the vasa previa or velamentous insertion or something like that?
Who is talking?
I'm Rekha Rajendra Kumar.
Oh, madam, thank you so much. I was waiting for this. It might be a fetal bleeding. And there was an evidence that it might be a fetal bleeding because the fetal heart sound started dropping dangerously to 70 and further low. So probably we are dealing with a vasa previa or something. So what I did was outlet forceps and delivery crash was a question of less than 100 seconds by clock. Do you agree with this? All my experts and all my participants.
Yes.
Yes.
All of you would have done this?
Yes.
Yes, sir.
Thank you. Thank you. Praful bhai, you are silent.
Yes, I said yes.
Oh, please, please, please. Your support is very necessary here. But then all hell broke loose. She started pouring and pouring blood. Manual removal of placenta accomplished within 30 seconds, and all the medical therapies were forced into action. These were the things which I tried to use, barring, of course, the last one, recombinant factor 7A. Anybody has got anything else to add to this? Patient is pouring. No. Anything new? That
Bimanual uterine massage.
Yes, bimanual.
It is a atonic PPH.
Right.
Misoprostol 800 per rectally can be tried.
Who is talking?
Dr. Jayashree.
Okay, may I request whosoever the participant participates to announce his or her name so that I can address you personally. So, misoprostol 800 microgram. Anybody who differs on this misoprostol business? Chintan, you are silent.
No, sir, I agree with you. I mean, whatever you did is the correct medical management.
We are talking about misoprostol.
This is besides.
Okay. Yeah, misoprostol, sir. I'm using it. I'm using it as the last resort after this oxytocin.
In this particular patient.
Yes, I would use it.
Misoprostol per rectally can be given.
Okay. Praful bhai?
I would use it 600 per rectal.
I prefer F2 alpha.
Okay, yeah.
I'm not using misoprostol much.
Will you please point out why you would prefer F2 alpha and not misoprostol? This is a very important point.
Well, I haven't used misoprostol much, although it has been said that it can be used when there are no trained people, prostaglandins. I mean, oxytocin is not available, ergot is, because it can be taken orally, vaginally, rectally, and so on. But I'm not too sure about the effects in such a catastrophic bleeding.
Agreed. I would agree with your last sentence that misoprostol is a very lazy.
I agree. This is only, sir, in case you said anything else can be tried. So
okay.
Misoprostol can be tried. Like
if everything is done, do something.
Yeah. The only option left. The only option left.
Otherwise, other things we can do.
Okay. So now it is clear that we are heading for something very catastrophic, and the obstetric collapse is round the corner or at the horizon, right?
Yes.
So everything depends upon what will be the blood loss. And do we have some specific, precise measure or method to estimate the blood loss?
Normally, sir, usually we put the collector dustbin kind of with there we can see the collected blood and the mops that we have used for mopping, and we can just assess the amount of blood loss.
I'm talking about immediate assessment. Let me put it in other terms.
Visually, normally we do visually in this catastrophic situation.
It is visual.
Yeah. Yes.
Yeah.
It is visual and clinical.
And clinical also, pulse rate and BP.
So we are coming to that.
Vitals, yes. And the vitals.
So is there blood loss, which we might visually assess and which would be grossly wrong more times than others, and which will underestimate the blood loss? Praful bhai, you agree to this? The visual estimation will be grossly less. Is there anything which will tell us that now this patient is heading for a collapse?
Clinical
judgment. Yes, sir. If the blood
pulse rate and pulse volume. Pulse, BP.
Pulse rate, pulse volume, and blood pressure.
Blood pressure, volume.
Patient compromised hemodynamically.
Yes.
Hemodynamically, then we should take that 30% loss is already occurred.
Yes. So the pulse rate and blood pressure, which we routinely accept as a parameter of circulatory compromise, are not valid in immediate postpartum patients. So there has to be some different types of scores which we need to undertake.
And therefore shock index is described, properly speaking.
Thank you.
Because the tachycardia comes much later and hypotension even later because of the sympathetic stimulation. The patient maintains the blood pressure in spite of massive blood loss until late and then suddenly collapses. The shock index helps better, it has been found. The shock index is the ratio of pulse rate or heart rate divided by the BP or blood pressure. And it has to be less than 0.9. The upper limit in obstetric patient is 0.9. So anything more than 1, the ratio, that patient is heading towards catastrophe or massive blood transfusion.
Thank you, sir. Thank you very much. I want all the participants to get this message across and get this message across very emphatically that our routine examination of pulse rate and blood pressure are not valid if we are discussing the immediate postpartum blood loss and the likely chances of patient getting shock or in collapse. So it will be the shock index which would help us. And then there are n number of scores which we are not going to discuss as of now. The time is running short, but the shock index, I think, would be strongly advocated. Would all my panelists and the experts with us agree with this statement and would pass it on as a take-home message?
Yes, sir.
Yes, sir. It's a unanimous thing, BJP versus Congress.
No, unanimous.
Thank you very much. There are a few more things, and everybody have come across this, that when you palpate, the placenta is not delivered, but the uterus is very firmly contracted. And still there is some amount of, we don't know what it is like, and the placenta has yet not delivered, has not yet separated. Anybody who has come across such incidences in practice? I think everybody has felt this.
Yes, so quite often it is the adherent placenta of some degree.
Okay. Chintan, you have anything to add?
Yes, sir. Sometimes, you feel the uterus is contracted, but still there is a lot of amount of bleeding which is coming from the placental side. So that may be that particular area is not contracting properly, and the bleeding is coming from that.
Can I toss this question into the audience? Anybody in the audience? Please put on your mute button and tell me. Okay, I'm tossing an idea, a thought-provoking question, that there are two types of oxytocin receptors in the myometrium. One which we all know, usual, but there is another oxytocin receptor which are specifically concentrated in the retroplacental myometrium, and they behave differently at times, and that is why rest of the uterus has contracted, but that subplacental myometrial oxytocin receptors are not behaving properly, and this is a situation where you find that the placenta has not separated and the rest of the uterus has contracted. This has been a very strong hypothesis circulating in the obstetric circle, especially amongst the basic scientists. I leave this question here open for a further process of thought amongst the experts, amongst the academicians, and amongst all. We are not passing this as a take-home message, but this is one thing which has been believed. There is
sometimes I would just like to add, sorry to interrupt, sir.
Yes.
Sometimes what happens. Okay, sorry, sir.
Sorry, Dr. Praful speaking. I'm saying that suppose rest of the myometrium is contracted and placental area is not contracted, how does it lead to bleeding? Because until the placenta separates, the major vessels are in the placental bed. So when if they don't contract and placenta is still attached, until then there shouldn't be massive BPH.
Exactly. So these are the issues which are not yet solved, but this is a hypothesis which has been circulating nowadays. Chintan bhai, tame kya kehta tha?
Actually, sometimes I'm talking after removal of placenta. Sometimes the reverse scenario happens that you find the uterus to be flabby, but surprisingly there is no bleeding.
No bleeding. Okay.
Now,
but there is some grain of truth in this. Requires further investigations by the basic scientists, especially, and of course the molecular scientists. Shall we move on from here?
Sure.
Yes. Sure.
Yes.
Thank you very much. There is another thing. Have you ever come across that patient is bleeding? You are trying some form of an uterine tamponade, and in spite of all your precise techniques and all the scrutiny which you have observed, the bulb of the catheter keeps on slipping down in the lower segment only, and the upper segment remains empty all the time. Anybody has experienced this situation once, twice, the balloon doesn't remain in the upper segment in whatever you do. Any idea? Anybody has
Prakash bhai,
this?
Prakash bhai.
Narendra bhai, yes, please.
There is a difference in the response to the oxytocin between the upper segment and the lower part.
Thank you, Narendra bhai. Please go ahead.
Yeah. So
between the gaps.
Yeah. So lower segment bleeding does not respond to oxytocin routinely because the way in which these living ligatures work with the contraction of the uterus with the response of oxytocin, this procedure does not occur in the lower segment.
Exactly. Now this thing came to fore. Can I add something to this? When people started studying what the upper segment and lower segment behaves like, and they studied it with a dynamic computed tomography scan. And what they found was that in patients who had PPH, the lower segment got unduly dilated and became almost as big as the upper segment. And these were the patients who were getting intractable, or what we call as refractory PPH. And this PPH was coming from lower segment around the lateral side of the internal os and not from the upper segment, though it lacked the uniformity. And the gate, which they called as between the lower segment and upper segment, was very narrow. So our balloon never could enter the upper segment. As a matter of fact, it was not required to enter the upper segment. If we could have inflated in the lower segment properly, probably it might have helped. So next time when we try the uterine tamponade, and if the balloon slips down, and if you find that the upper segment is reasonably well contracted, don't worry, keep the balloon in the lower segment, inflate it further, perhaps you might be able to control it. So this is another thought which I am propagating at present. I am not saying that this is a take-home message. I want all my colleagues to think about it. And whenever they encounter such a situation, whether they can correlate with this, what I am trying to say. Will it be all right? Shall I move with the... Thank you, Arif. Thank you. So this was what it has been done. Now, this is one thing which I want to emphasize. This is from me. Atonic PPH has a significant subtype known as praise. This is not the praise which we generally find during eclampsia. This is characterized by refractory PPH, resistance to treatment, arterial contrast exit, and it needs for embolization in an early phase rather than in the late phase. So we are going to use the uterine artery embolization or internal iliac artery embolization in treating our PPH cases. And in those cases where you find this thing, where there is an arterial contrast extravasation, you need to embolize it earlier. This is something which has come up, and we are still looking at it. The basic scientists and the radiologists are looking at it. But this is one thing which might solve several of our problems and save several of our maternal mortalities. This is just for this. Yes, please.
For embolization to happen, the patient has to be hemodynamically stable. And most of the time when patient is shifted, the patient has already collapsed or is not hemodynamically stable. So this part normally doesn't work well.
May I know who is speaking?
I'm Dr. Jayashree from Vapi, sir.
Jayashree Kapadia, thank you for coming on the board. Yes, I agree. I had also the similar doubts when I read this for the first time. But then you mark this, what shall I say, something sort of a definition in which they have specifically said that the PPH which is resistant to treatment, and this bleeding is coming from the arterial side, that is contrast extravasation is arterial and not venous. And therefore, this is the bleeding which is very much amenable to embolization. Those of you who have tried this uterine artery embolization or embolization to those vessels which are coming and you don't know from where they are coming, you will see that interventional radiologists will tell you that if you find that there is a leak, then it is an arterial leak. If it is a venous oozing, you will not find the leak. Am I right, Narendra bhai?
We had a case in our patient.
Yes, this has happened in our patient.
Yeah.
So there was a leak, and therefore it was an arterial embolization, and the arterial leak and embolization would work in that. If it is a venous oozing, embolization will not work. So, Madam Kapadia, this is what has happened. I agree with you. I had a similar doubt when I heard this, when I read this, but then my doubt was cleared, of course, after I had a very bitter experience in this patient. Anyway, now there is one
in
more
Surat,
thing.
they do uterine artery embolization. I mean, there are people who are doing
Yes,
it
yes.
because
There are now
in Bharuch
number
we
of
don't get.
people, fortunately.
Yes.
Fortunately, we have number of people now.
Many of them and doing very expertly. Yes.
Very, very well. Yes.
That's so nice because in Bharuch we don't have any people.
Send them to Surat.
Same day.
I wish the patient has a time to for that.
Yeah. Now,
Whenever the catastrophe happens.
yeah, we all have been talking about whether this PPH which we are witnessing is leading to something very sinister, or is going to respond to our medical line of treatment, or is going to respond to our procedures. There is something more which I think we need, because all our parameters, whatever we have available, have failed to predict whether this PPH will proceed further, will this PPH create problems, become a catastrophe, or will be able to control it with our medical line of treatment or simple surgical procedures. Can you think of something further than this? Any idea? I request all
Sir,
of
one question. Is there any role of cannulas in this atonic PPH?
Yes, yes. Thank you for bringing it out. It is from Dr. Panikar.
Panikar
Yes.
cannula.
Yes.
Panikar,
Madam, you are Dr. Puresha.
Puresha, yes.
Yes, yes, yes. Dr. Panikar. I'm going to show the photograph of those. What shall
I
I say?
have, sir. I have it.
I have got it.
I have
also
also
got it.
used
Yes.
them with good result.
Yes, with good
Yes, sir.
result.
Fortunately, I never had a chance to use it, or probably I was so biased that I didn't use it that often. Anyway, but coming back to that prediction and of PPH getting catastrophic, there is something which I want to emphasize. Why I want to emphasize this is because 10 years down the line, we all are going to use this. I will not be there, but all of you will be there. So this is what we are going to use it, because now we know that the sensitivity and specificity of our standard coagulant cells tests are very, very poor as far as predicting PPH is concerned. They do not answer our questions, and there are valid scientific reasons for it also. Only thing is we have never thought about it. And now let us start thinking about it, because there are people who are thinking. Any comments? This is the first thing which I am bringing out.
Prakash bhai, can we take fibrinogen in that?
Yes, exactly. We have reached there at least, the fibrinogen. But the trouble is, Narendra bhai, what is the trouble?
Yes.
Fibrinogen will be the last result being available. And
Yeah,
it will
our
take
labs
at
are.
least 1.5
Yes,
hours.
yes, yes, you're right.
इन सब में फाइब्रिनोजन का रिजल्ट एट लास्ट ही आता है, उसके पहले आता ही नहीं है. Otherwise, fibrinogen is the most sensitive marker of PPH, but we are not getting it. So there is something interesting. What is popularly known as point of care? Any idea? Anybody?
Sir, point of care is mostly the coagulating test and vasoelastic test which are included in it.
Yes. Who is
Yes.
talking? Who is talking?
Dr. Hiral, sir.
Oh, Hiral Ben, आपने मेरे मुंह की बात छीन ली, हाँ? Great. So I am talking about in settings of obstetric hemorrhage, we have viscoelastic assays. And you might think that this is not available in India, but I remember around 2.5 to 3 years back, before Corona, there was one person, a blood transfusion officer from Bombay, Harkishan Das Hospital. And there we were discussing this, and he said that they have got this and they are routinely using it.
Sir, one more thing. We used to do in our labor room clot retraction test. Somewhat
That is
simple.
very long. Praful bhai would remember. Right? Yes.
Yeah, simple. Take it in a plain test tube and observe the clot.
Yes,
Yeah.
exactly.
And we were doing
How
it
long does
every
it take to
IUFD.
form the clot, and how firm or soft the clot is?
Yeah.
Yes, exactly. So this is a more precise, more specific, and a mechanized version of that clot retraction test.
Exactly.
So this is going to be the TEG and the thromboelastometry. This is just for the sake of information. This is not a take-home message, but I would request the young generation to remain ready how to use all this before you start using robots and AIs in your laparoscopic surgeries, right? So this is just for the sake of illustration. The first is of a normal patient. She is bleeding, but she is going to recover. This is that graph. And the next one is, this is a patient who is also bleeding, and the person knows that this patient is not going to recover. So that is how this TEG and ROTEM have been used. And this is used especially in refractory PPH. Dr. Kapadia, this is your Panicus cannula.
So there is one more called Dr. Samartharam's cannula also available. Which is,
I have no idea about this.
No, that's what
how
I'm
Samartha
saying.
is that Samartharam's cannula.
yeah, but just wanted to tell you that he's also been doing a lot of work on this.
Yeah. Anybody else have used such cannulae in PPH cases?
I haven't used.
No, sir, not used.
Not used.
No, I
Narendra,
have not used. I'm having this
Sir,
cannula, but I
Yes,
have
sir,
never
we are
got a
having
chance
this
to use it.
cannula, but not used.
Prakash bhai, I have been
anybody from the rest of the participants?
We have the cannula, but we've seen the demo, not done it.
Fortunate enough not to
Okay,
use.
I have got them, but I have not used.
Yes, sir.
And then, of course, there are a lot many things, non-pneumatic anti-shock garments and uterine tamponades and all. We are not going into procedures. We all have by now mastered the procedures. We know what are compression sutures and we know what are the stepwise devascularizations. And then, if the time would have permitted, I would have loved to talk about the recent, immediate and late complications, but there is not much of time. So now I will invite Dr. Chintan Bhai to start with his second case. Chintan
I'm
Bhai,
just sharing
go
my
ahead.
screen.
Chintan Bhai, please go ahead.
Sir, you have to stop sharing your screen. Okay.
Okay, I will stop
Fine,
sharing
fine.
my screen.
Okay. So this is a question to Dr. Jayshivan. Just to, to start a topic, we need to define what the sudden obstetric collapse is. Dr. Jayshivan, can you please?
Sudden obstetric collapse is sudden loss of consciousness of a patient who is undergoing delivery, and it could be a plain cardiac event, or it could be secondary to any cardiovascular event.
Okay. Okay. So in literature, they've said that it's an acute event involving cardiorespiratory systems and or brain, resulting in a reduced or absent consciousness level and potentially death. Okay. So we all know, we have a very good graph. This is available on net. What are the causes of sudden obstetric collapse? Starting from the brain, the eclampsia working at that. Then at pulmonary level, pulmonary embolism, amniotic fluid embolism, the drug interactions like magnesium sulfate that we commonly use, local anesthetic or illicit drugs. The hemorrhage, as sir already mentioned, which is the major cause of the sudden obstetric hemorrhage. There could be anaphylaxis to some drugs or some other things. In the heart, it could be aortic dissection, cardiac causes, and could be some metabolic causes or sepsis. So this is just to enumerate the list that we mentioned. I would like to divide this the causes that cause sudden obstetric collapse into two categories. One which is obviously known causes, and the other one which is sudden collapse with unknown etiology that strikes us as an obstetric enigma. What is the known etiology? The postpartum hemorrhage, the cardiac causes, the inversion of the uterus, and anesthetic causes like high spinal. What are the unknown causes where we are blown in dark? That is amniotic fluid embolism, drug overdose or toxicity, and pulmonary embolism. So now I would like to start the case, and we will discuss what should be done within the case. The case, there was a 25-year-old second gravida. She was unregistered patient. This is in COVID era. She came with a complaint of labor pain since morning, and the pain was associated with contractions at 15 minutes interval. She was a second gravida with previous live female child. Her menstrual history and the past history was nothing significant. Her ANC profile was normal on admission. And on admission, when the sonography was done, it was a single live intrauterine fetus with normal Doppler findings, and fetal weight was around 2.7. Everything was normal. So there was no history of routine medication or past history. She was non-diabetic. Regarding COVID status, not known, but she had been vaccinated. Now on examination, her vitals were stable. General condition was fair. On per abdomen examination, the uterus was full term with FHS normal and mild contractions. And on PV examination, she had a 2 centimeter 30% dilatation with -1 station. The routine management was started, as everybody would agree. She was allowed to go into spontaneous labor. Serial observation was done. In the morning, 8 o'clock, she had around 4 to 5 centimeter dilatation. So the progress was satisfactory, and it was a spontaneous labor. Then at this juncture, ARM was done. Pitocin drip was started, and then it was accelerated every 45 minutes. There was a good progress of labor, and by noon, the patient had an active. She was in active second stage of labor, and she delivered a healthy baby, which cried immediately. 2.7 kg healthy female child. Now what? Now every good part is over now. Now the problem has begun. The patient has started showing fits, tonic-clonic in nature, 5 reps, and suddenly she became unresponsive and looked confused, disoriented. Placenta was yet to be delivered. I would like to start with Dr. Praful Doshi, sir. Sir, what would be your initial impression? I mean, the baby has delivered. Placenta is left, and she has started tonic-clonic convulsion.
I've seen convulsions with inadvertent injection of local anesthetic in the intravenous.
Right.
That you give for episiotomy, or sometimes we used to give it for low forceps, where we used to inject 10 ml on each side near ischial spine, and so the total volume became 10 plus 10 and 10 for episiotomy, 30 ml, and that is
Right,
when chain convulsions.
Well said, sir. Lignocaine, inadvertent given or higher dose given, it does cause the toxicity, and it's a major cause. Anybody else? Dr. Qureshi, ma'am, any other cause would you like to put?
Could be
an air
eclampsia,
embolism,
hypoxia.
air embolism, having a cerebral event.
Embolism, we do put which sort of embolism? We put it. We discuss it later. But okay.
Amniotic fluid
Amniotic
embolism.
fluid embolism.
Amniotic fluid embolism. We can put.
And third thing is, sometimes there are a case of epilepsy.
Yeah.
They would not have told
Well
us
said,
not
ma'am.
taking the drug.
Yes.
Well said, ma'am.
Distress of
that
labor
could be-
itself has created in one of my patients.
That could be a hidden history.
Yeah.
Or she could have an epileptic fit.
Or it may be the first episode also because of the labor distress.
True. And she might have an eclampsia with it was hidden with a normal blood pressure. We do find. So this was the possibility put forward: eclampsia, epilepsy, anaphylaxis. There could be some cardiac problem which has aggravated, and amniotic fluid embolism. Okay, so any obstetric, any such sort of obstetric collapse if happens, I would like to ask Dr. Hiral, what would be your first step?
Hello, tell everybody to mute this thing. I can hear somebody talking.
Patel sir, can you mute yourself? Patel sir?
Yes, we do hear some conversation.
Please request everybody to mute their. Except the panelists, everybody should mute their phone.
Okay.
આપણી પોલિસી નક્કી કરી લેવી પડે પછી એ પોલિસીને એક્ઝિક્યુટ કરવા માટે કોને કોને ઉમેરવાના
Can I request Mehul to please mute, I mean, if he can find out and mute the person whose voice is coming.
Yes, done, sir, done.
Okay. Okay. So, Dr. Hiral, what would be your first movement whenever you find such sort of sudden obstetric collapse?
Sir, secure
Within given-
airway, breathing and circulation first. If she is convulsing and if she is going for unconscious, we should prevent her tongue fall. A proper vein is already secure because she is already delivered. And we should go for her vital monitoring. If it is eclampsia, we should treat accordingly with a Maxal Fragile. And if it is, if she, with the history of her relatives, if she turns out to be epileptic, then we should go for anti-epileptic drugs.
So, in nutshell, we have to first of all, we have to resuscitate the patient, whatever the cause it is. And at the same time or afterwards, we should try to know and find out and treat the cause, right? Usually we have to do it simultaneously, but obviously the resuscitation of the patient has to proceed. So this is the list how the emergency management has to be done. We all know the ABCs of the protocol and all that. One thing here I would just like to emphasize is we all should be as an obstetrician, we are very likely to face this sort of catastrophe in our life. So we should all be well trained in at least initial resuscitation of the patient, because whomsoever we call, they cannot come within just 20 minutes or so. And at that time, we have to manage the patient. So I think everyone of us should be well trained with the resuscitation of adult as well as neonate, and intubation, emergency intubation should be a part of our training.
Now, one more thing, sir, I would like to say.
Yes.
If intubation for few people might we might not be thorough with because we don't do it routinely, but we can keep iGel for neonate as well as adult, which can help
That's
us
true.
With easy ambu.
Yes, Hiral, I do agree. I mean the intubation is a gold standard, but okay, fine. If you are not conversant with at least you should have an iGel, that is a laryngeal airway, and that can be very vital in such sort of situations where where you find your saturation of the patient is falling and patient is sinking in front of you, and anesthetist or intensivist is yet to arrive. Anyway, further moving towards the case, then patient become pulseless and BP was unrecordable. Heart was auscultated, which revealed absent heart sound. So that was a cardiac arrest. And CPR was started. Cardiac thumping helped, which helped the patient to recover a little, and the feeble heart sounds were heard. Now, what will we do? I think my next question would be to Dr. Jayashree, ma'am. Ma'am, what would be the we have started resuscitation and it has showed initial response. What would be your next step?
4H, it said 4H. So hypovolemia has to be corrected, then hypothermia, hypokalemia, and hypoxia. So that way, if the patient is hypovolemic, the crystalloids has to be given. If we are waiting for the blood products, then colloids should be started, then blood products. And then if the patient is pulseless and is like low volume pulse, pneumatic garments can be put. Then that will help in hypothermia also. And oxygen 100 liter, at least 100%, 15 liters at least should go. And by the time we should monitor the patient. And if hypokalemia is there, that should be corrected. Then according to the etiology, we should further move.
And sir, while doing CPR, we should call
right,
our
but
physician.
Right now, our patient has just started, coming out and showing the heartbeats. I think it's too early to look for the cause, what has happened.
Sir,
so I
while
think
doing
the next
CPR,
step,
we should
Yes.
call anesthetist and physician for help.
yes. So the next step now, after the initial resuscitation has helped, I think an expert would be intensivist or an anesthetist would be a better person to take over, which was done. Patient was intubated and she was put on external circuit ventilator. Still, the patient remained pulseless and BP was not recordable. Patient was confused and poorly responsive. She did respond to verbal commands occasionally. So then it comes a higher level management. After the initial ABCs are over, we have to go for an emergency management too. That is, if the mother is not breathing, you have to provide oxygen and artificially ventilation. If there are no carotid pulsation, you can go ahead with external cardiac massage, and the ratio has to be 30:2, external massage and respiration. There could be different treatments of ventricular fibrillation, ventricular asystole. Not going into the detail of that because this would come in under the purview of intensivist who has already arrived. One thing I would like to emphasize here is the role of emergency uterine evacuation. May I go again to Dr. Praful Doshi sir? Sir, suppose this patient had delivered, but suppose this patient had not delivered, and the baby was inside. Would you like to go for an emergency uterine evacuation to help the patient, not for the baby?
It's a very tricky question, and in this medico-legal atmosphere, it's very difficult to the act of omission and act of commission, which were just described. Sometimes when you try to take out the baby immediately, not to save the baby, but to reduce the load from the mother for whatever unexpected reasons, and the patient dies, then it may be considered an act of commission.
Complication of surgery.
Died because of your surgery. So most people, including me in such situation, will let the baby go and concentrate on the mother.
Yes, sir. But this is the point. I fully agree that medico-legally it is very difficult step to go for. But in literature, it has been mentioned that whatever the baby's condition is, evacuating the mother in this state definitely helps to recover her hemodynamic status, and it should be done by any competent person present without waiting for the anesthesia. But I do agree that it's a controversial issue as far as the medico-legal consequences are taken care of.
Maybe a few decades back, I would have done it. Sure. The present times, I'm not so sure about doing it.
Perimortem delivery.
Perimortem cesarean.
It's a perimortem delivery. Exactly.
Within say 4 minutes of not getting the pulse.
Right. So moving further in the case, meanwhile, the placenta was delivered and episiotomy was sutured. The per abdomen uterus was well contracted, size below the umbilicus, no bleeding per vaginum, and the patient was on full inotrope support like IV adrenaline, IV atropine, noradrenaline drip, and the patient was shifted to ICU under physician. In ICU, the patient responded to verbal commands. So things getting better and better, and the sigh of relief. She was on noradrenaline drip. BP was then recordable. Oxygen was normal. Hypotension, tachycardia sustained for 2 hours, but the patient remained conscious, and the patient informed obstetrician that okay, now you can go and have some sleep because the patient shows the signs of recovery. What next? This question I would like to go to Dr. Quresha ma'am. Ma'am, now after this discussion, we are mostly putting a diagnosis of probably some form of amniotic fluid embolism in this patient. What would you anticipate now in this patient? The patient has been resuscitated and she has shown signs of the cardiorespiratory arrest is starting recovering. What would you expect next? Anybody else would like to take the question?
The patient may be going towards DIC. So we have to be watchful. We have to be watchful for that.
Exactly.
Quresha, unmute yourself. Quresha. Unmute
Okay.
yourself. You are
Okay,
mute.
okay, sure.
Okay. Madam,
Yes.
anything, Kurisha ma'am, anything you want to add
Yes,
from your side?
we will definitely monitor her for the coagulation profile and for the bleeding PPH. If we are diagnosis, it is a amniotic fluid embolism.
And
So
another
we will
thing-
start sending the blood samples for the all coagulation profile, and we will monitor her for the DIC.
And another thing is unexpected thrombotic attacks also.
Yes.
True. True. So a very important point to bring about that whenever such sort of patients they are recovering, the next event immediately likely to pursue is the DIC and intractable PPH, which unfortunately happened in this case when while the patient was at the physician's place ICU, he had developed severe PPH, and unfortunately we lost the patient due to heavy bleeding. Now. Nothing was to be done. I mean, at that setup, it was hardly anything could be done to prevent that PPH. And the only thing what we could do is putting a diagnosis on a retrospective base. So, Dr. Pratichi, what would you think in this case?
Yeah, in this case, the most common diagnosis we come forward with is amniotic fluid embolism, but it's secondary PPH and cardiac arrest due to that. And the other different diagnosis will be the shock syndrome due to vasovagal shock or hemorrhagic shock, or some unknown cardiac cause, or the cerebral cause, as is post-ictal or eclampsia or cerebral vascular accident.
True. Exactly. So that would be a list of differential diagnosis with most probable diagnosis having amniotic fluid embolism, which we put forward. Okay. Now just going towards the resuscitation part. What way the obstetric patient differs from other adult patients as far as the physiology is concerned. Can I go to Dr. Hiral for this question?
Sir, in obstetric patient, all the physiology is altered, whether you say for respiratory physiology, circulatory physiology, cardiac physiology, there is increase in blood volume, there is hemodilution. So we can say that at each stage, a non-pregnant female and a pregnant female is the physiology is different.
True. The most important aspect that all the altered physiology which is mentioned here, it makes the resuscitation of obstetric patient more difficult than the resuscitation of a normal adult patient, and this criteria have to be taken in mind. I would not go into the very much detail of that, but one thing I would like to add here, put forward here is whenever you are resuscitating an obstetric patient, probably with more than 6 months of pregnancy, just do it with a 15-degree tilt. Whether you are the patient, if fortunately if she is on an OT table, you can just have a lateral tilt of the table while resuscitating, and if she is on floor, you can just put on right side or that some pillow or some sandbag or kind of that, so that the patient remains into a slightly tilted position. Okay. The amniotic fluid embolism, it's a catastrophic obstetric complication presenting as a complex sequence of peripartum events that results in cardiovascular complex and disseminated intravascular coagulation. Now, recognition of true incidence and mortality rates with AFE, they are confounded by several factors. But, we all know that, it's very difficult to establish the diagnosis of amniotic fluid embolism when the patient is live. Most probably it's a post-mortem diagnosis or kind of that, or it's a clinical diagnosis. The existence of several different international criteria are there for the risk factors diagnosis and for the understanding of this physiology. I would like to add one more point regarding AFE. Can somebody tell me regarding what are the categories of AFE? Dr. Praful Doshi sir, can I have you on for this answer?
I'm not sure about categories. Most of the time, it is when we can't explain by any other obvious reasons, we call it AFE. And the DIC immediately coming after that clinches our diagnosis, because many other cerebral causes or cardiac causes will not lead to DIC as much as the AFE leads to. So, and even post-mortem diagnosis is like if you have diagnosed amniotic fluid embolism and tell or advise the patient for post-mortem, and then post-mortem sometimes doesn't reveal, then you are in a kind of a catch, because very difficult to diagnose amniotic fluid embolism even in post-mortem cases. So most of the time, as you said, it is clinical diagnosis.
To clinch a diagnosis on post-mortem, you have to have amniotic cells, amniotic fluid cells within the pulmonary vessels at the time of post-mortem.
So it really requires a very expert forensic mortem and not the routine RMO post-mortem that in a peripheral.
Should I finish here?
May I add something?
Yes. Okay. Yes, Narendra sir.
May I add something?
Please, sir.
Yeah. So the correct word is anaphylactoid syndrome of pregnancy. You may not find presence of these fetal elements in pulmonary tree. Even in cases of pulmonary embolism also, picture is little bit different. Patient will become tachypneic, there will be syncope, there will be, suddenly patient will be having the shortness of breath. It's okay. But the thing is, what I would like to say is every obstetrician must know intubation, because these are the patients who die because of hypoxic ischemic encephalopathy. By the time your anesthetist comes, or even if you want to refer these patients, always refer these patients with tube inside. Otherwise, these patients will die because of brain damage.
I strongly believe that we must know the adult intubation as well as neonatal intubation. That must be a part of our curriculum. Anyway, yes. Sir, according to the literature, it has been the amniotic fluid embolism divided into 3 groups. Typical amniotic fluid embolism, a distinct diagnosis other than amniotic fluid embolism, and indeterminate diagnosis. But there are some, we broadly divide this into typical AFE and atypical AFE. There are some criteria, as Narendra sir mentioned, for amniotic, to suspect a diagnosis of amniotic fluid embolism. And the criteria are: there should be a sudden onset of cardiorespiratory arrest, there should be a respiratory compromise, there should be an overt DIC, there should be onset, it should be onset during labor, cesarean delivery, or dilatation or evacuation, or within 30 minutes of delivery of placenta, and there should be no fever. Now, all the criteria may not be present in every case, but if you look at the typical or atypical amniotic fluid embolism, and if you compare these two, then if there is a typical AFE, usually all the 5 criteria are present. But in case of atypical amniotic fluid embolism, the first 3 criteria may be present, may or may not be present. And but it's just a theoretical exercise whether it's a typical or an atypical amniotic fluid embolism. But there are some criteria to suspect your diagnosis. And fortunately, previously the maternal and fetal outcome, which used to be a very grave in case of amniotic fluid embolism, now the survival rate as far as the mother and fetus are concerned, they have improved dramatically, and thanks to all the better intensive care and better gadgets that are available to us for the diagnosis as well as the treatment. And there are some recommendations for managing the amniotic fluid embolism. I think we should, since we are running short of time, I would just like to have a word about early warning score. Can anybody throw a light? What is early warning score? Anyone from us?
So it's depending upon the vitals, you have to check, like the pulse, if it is feeble, if it's normal, or there is a tachycardia, there is a progression like normal, then there is a compensatory tachycardia, and then there is a feeble pulse. Similarly, you can check the blood pressure. So according to the vitals, then the BP and then the SpO2, you can check. These are the early warning signs from where we
Okay.
can.
Correctly said, Dr. Jayashree. Actually, it was a guide used for the medical services in UK. And this was developed for the nursing staff in NHS system based on vital signs, respiratory rate, oxygen saturation, temperature, blood pressure, pulse and heart, and all that. In early 90s, this score was devised. And according to this score, they used to predict the patients who are likely to go for a sudden collapse or sudden death, or the patients who are likely require the to admission in an intensive care unit.
So normally, if the
PWS
if the patient is having a very feeble pulse, then it's a high risk. Then if it's a tachycardia, it will be a moderate risk. Similarly, BP, if it is
yes, madam. So that is a score. A score has been given. And, yeah, and if the score is 5 or more, the patient is likely to have an increased likelihood of death or admission to intensive care unit. There are different scores being devised for different groups. For maternity, the modified early obstetric warning score has been devised by that. But I mean, we don't have that such scoring system, but we can definitely have some criteria.
I think the topic that we are discussing is sudden collapse. Like the obstetric collapse is the speed with which it occurs. So when it starts occurring, then this scores can rapidly rise, and we don't have time to score and find out. When probably midwives or nurses level they are managing, and then they have to send to somebody. So this is like it's not about catastrophic or massive hemorrhage, but then if patient is deteriorating, they can refer. But the collapse does not define the term collapse is different. Here the speed is very important, and the speed with which patient deteriorates is like confuses everybody. You don't have any scoring system or anything. You just start resuscitating.
No, sir. This was just to be prepared for some patient who is likely to go for some form of catastrophe or kind of that. This is not when it actually happens. The scoring doesn't work when it actually happens. I fully agree to that.
Yeah.
Anyway, sir, my topic is over. I would just like to hand over to Dr. Prakash, sir.
Thank you, Chintan Bhai. I think it is 9:45 plus. So I think we should call a day at this moment, rather say call a night at this moment. And we'll keep the third case for some other event or for some other opportunity, because it's getting pretty late. Are all my panelists
finish off?
Or you want the third case to go ahead?
Yeah. Quickly brush through so that you can complete.
Okay, no, we are not here to complete anything, madam.
No, not like that. We will have a complete idea of what you are talking, like what the third case would be.
Okay. Chintan Bhai, will you please stop sharing us?
Yes, sir.
Thank you. Well, this is another case. This is AB G7P3. 3 tops, 3 live daughters. And you know why then the tops were.
No, we are not able to see the screen.
What do you say? I already shared it.
No, sir, it's not visible.
Just a moment, let me see. Now, are you able to see now?
No, sir.
No.
I don't know what has happened. Mehul?
Stop
Yes, sir.
and reshare, sir.
Let me see again.
Yes,
Let me
yes,
try
sir.
again.
It's completely blank.
What has happened? Mehul?
Yeah, yes, sir.
There? Please help me.
It's
Sir,
a
stop
completely blank,
sharing.
sir. You just unshare and then share again.
Let me
Stop
stop
share
it.
and then reshare.
Yeah.
Okay, now I'm sharing it again.
Yeah, now visible.
Has it appeared?
Yeah.
Yes, yes.
Yeah, okay, thanks. Now here was a Gravida 7 and Para 3rd. She had first 2 vaginal deliveries, then 2 terminations of pregnancies, and the 5th was a cesarean section carried out for fetal compromise, indicated by a thick meconium passage during early first stage. She was 37 weeks pregnant with an absolutely normal antenatal period when one day she noticed a red colored urine in the morning. She went to her institute. She looked pale, otherwise there was no abnormality, normotensive, and came for a second opinion. Uterus was not contracting, nearly full-term baby, everything fine, no sign of recent bleeding on inspection of cervix and vagina. Os was closed, cervix was long. We advised her to collect a midstream specimen carefully. That was also hemorrhagic and uniformly blood-stained. No other urinary symptoms. Her original ultrasound revealed 36 weeks live baby presenting by head with normal vascular spectrum and normal amniotic fluid embolism, amniotic fluid volume. This embolism has got into me, huh, Chintan bhai? But there was a central placenta previa, and placenta was passing over the expected place of previous cesarean section incision. Fortunately or unfortunately, I smelled the rat and asked her to get admitted at a multi-speciality unit of our city, where she managed to reach at 9 p.m. And you know what happens at 9 p.m. when somebody is admitted. Nothing additional came up in history, clinical examination by our emergency medical officer, who is very thorough in her history taking. We redid everything, practically nothing except severe anemia, 6.3 grams hemoglobin. I dragged that sonologist out of his bed and asked him to do the ultrasound and do a color Doppler. And what he came up with was something which was absolutely alarming. He said that the placental vascular pattern is grossly abnormal. There is no distinction between placental and maternal vasculature. And he strongly suspected placenta accreta. Clinically, do you think it was a placenta percreta and not accreta? What are my learned participants thinking?
Yes. So it's placenta percreta.
Percreta. It's not percreta?
It
looks
is.
like accreta.
Percreta, sir.
Percreta. What leads you to think like that?
Reddish color urine.
Reddish color urine. Yes, yes. That had put me on alert. And I thank that reddish color urine because it did put me on alert. What the incidences that happened later on proved. So what I did, let us have an MRI confirmation next day. So now next day, if the MRI confirms that this is placenta percreta, what do you plan? And whether what I planned was right or not. I would like to compare my planning with your planning. Let's begin from, let us say, who has been exceptionally silent all throughout. Dr. Kapadia, Jayashri-ben.
Yes, sir.
I have not heard enough of you.
Is it, sir?
Yeah.
I gave so many answers.
Okay, then I must be doing something else. Anyway,
Sir,
what do you think?
Sir, if you are suspecting a percreta, then if you are in a setup of, I am not in a setup where embolization is done, but if it is available, then keeping everything ready, go for a cesarean section and go for radiological arterial embolization.
Okay, okay, thank you so much.
This is in metropolitan cities, but
Yes,
I am
sir.
in a setup where this facility is not available.
Right,
So
right.
in-
Everybody cannot be living in an antella with Mukesh Ambani, right?
Yes, sir.
So-
So we can go for a cesarean section, taking consent for hysterectomy
Hysterectomy, right, right.
and keeping a urologist along with you.
Thank you for saying that. Thank you for saying that. Dr. Quresha, what is your plan? Dr. Kuresa is there or she has deserted us? She is not around. Okay. Pratichi.
Yes, sir. So definitely we will deliver the patient in a tertiary care unit where also the ICU management is available. And as Jayshree ma'am already said, that we will need a surgical assistant along with us. And also I am living in Valsad, so the routine radiological procedure is not done here. So the consent of hysterectomy along with if there is a need that blood invasion is more, we may need the urosurgeon along with us in the operation theater, and
So
also reserve the blood.
Yeah, reserve the blood. I think we all are talking on the same tune. We are on the same platform that we might need a urologist, and we need to have a radiologist services available if we have the services there. And that is what I said. I alerted the neurosurgeon, one of my good friends, and then talked with one of my friends. He was the only interventional radiologist available at that time in Surat. So we decided that we'll put a catheter inside in the internal iliac or uterine in the cardiac cath lab, take her to OT, and then block those catheters in OT, and then do a crash classical cesarean. I didn't want to compromise the blood supply for any longer than what is strictly necessary. Do you agree with this? Or you would like to embolize it first and then go for a cesarean?
No, what you did was right.
Okay, thank you so much. And then, of course, we'll go for a hysterectomy. So, what they say, the man proposes and the God disposes. Patient ruptured her membrane spontaneously at around 1:30 to 2 a.m. at night. So, the liquor was meconium stain. And the radiologist was still out of station, had not managed to reach Surat. So, what do you plan now?
Need to take the C-section along
Yes,
with
yes. As they say, himmat marda to madade na khuda. Let me see whether na khuda comes to my aid or not. I had an urgent laparotomy. On laparotomy, we found that she had a placenta percreta encroaching into the urinary bladder. It was fortunate that I had already referred her to the urologist, and that urologist remains so busy that he always comes for his evening round after 11 p.m. So he had at least a look at the patient's face that, yes, this is the patient who might call me anytime. So I managed to drag him out of his bed at 2 a.m. and brought him to the OT of that multi-speciality institute. Of course, the delivery was easy, right? Classical cesarean. Will not attempt a lower segment cesarean section. No niceties now. Hysterectomy was decided. Total or subtotal?
Total.
Unanimously total, right?
Yes.
And there the trouble starts. The separating the bladder from the lower segment and coagulating the vessels or preventing the hemorrhage from extensive collaterals. There was nothing but collaterals. Even that urologist also couldn't accomplish it. And I remember him telling me very clearly, Prakash, I think I will take the fistula rather than the death slip. Let me ligate the superior vesical artery. By that time, we had ligated the internal iliacs, we had ligated the uterines, we had ligated the uterovarians, and chopped off that much of uterus, amputated just below the uterines. But the rest was bleeding and bleeding like a hell. So we had all feeding vessels ligated, but the bleeding from anastomotic vessels were extremely severe and was absolutely unsurmountable. All the attempts at hemostasis failed. All the ligations had led to nothing but no amount of work was helping us. The vascularity that had developed because of collaterals was bleeding on our head like a hell. So now what to do? Now here I want everybody's opinion, whosoever is present. Shall we start with Chintan Bhai? Kahan gaya?
Yes, sir. Sir, fortunately, I have not landed in this sort of situation anytime. I have managed up to placenta accreta only. But then one thing came into my mind that before resorting to the obstetric hysterectomy, can we just ligate the interiliac artery?
They have
in
been done
prior-
already. All of those ligates, we had all likely feeding vessels ligated.
Prior to hysterectomy?
Yes, descending cervical, internal iliac, everything.
I didn't get that. Could you try again?
So, any brilliant ideas from anybody?
Sir,
Sir, embolism, uterine artery embolism.
Excuse me, I didn't hear you.
Prakash sir.
Huh.
I'm not sure, but we can remove the cervical part, letting some cervical tissue which is attached to the bladder and remove the maximum part of it. I'm not sure. I'm just speculating.
Okay. I welcome those speculations because I also had an iota of that temptation on table. Praful bhai che ke chhodi gaya?
Sir, he left.
He left. Oh, so sorry.
Hello.
Anybody else?
Sir,
Hello.
I'll just
Aortic compression.
Aortic compression. That's how long? And
Sir,
for how much
pressure.
time?
And then
Sir, proper pressure on the bleeding spot and taking some square sutures or something.
Okay, but these are all collaterals bleeding from everywhere and anywhere that find, because the collaterals have no directions.
Yeah, because
they
you
have
have
no origin,
ligated
nothing.
possible.
Yeah.
Sir, how much was there left inside the abdomen? I mean, hysterectomy was done, right? All the
Subtotal.
feeding.
Abhi,
Subtotal
fix up karne ki
hysterectomy was
baki
done.
hai, हाँ.
And bladder was attached to that.
Attached, but the
obviously.
problem was not bladder. We were ready to sacrifice one of the walls of the bladder and later on repair it. The problem was the collaterals which had completely filled the pelvis.
embolism of main vessel.
Internal iliac ligated.
Madam, all feeding vessels were ligated.
Feeding vessel.
So besides,
We could not find any origin of any vessel anywhere.
But we will do the arteriogram or something, and we will.
But which
This patient
Embolization
has already gone into some form of coagulopathy.
Now I will tell you what I did.
Hello,
I will tell you what
Prakash
I did. The most
Yes.
primitive method of hemostasis was tried. I am omitting all this. These are all very important things, but we don't have time. So we go back to the operation table. So what I did was, I took mops and packed 6 mops in the pelvis.
That is exactly what I told.
And kept them pressed for 15 minutes and then didn't remove them.
That
I
is
kept
what
them
I
there
told.
only because I felt that the prudence was better part of the valor. And we closed the abdomen with 5 mops and 2 large size abdominal drains. And there was one thing which we promised to ourselves optimistically, that after 40 hours, we'll come back and we'll remove those mops if those 40 hours are existing. Because by that time, patient had lost her pulse, lost her BP, and she had received 15 units of PCV, 18 units of FFP, 30 units of cryo, 8 units of PRP. On table, the loss of fluid, mostly blood, was 7.5 liters, and it was 7 o'clock in the morning. We started at 2, 5 hours gone. But when we transferred her, her clinical vitals were acceptable. Her peripheral oxygen level was 94%. Her arterial blood gas studies were normal, and she was maintaining her blood pressure with a noradrenaline drip. So that was the story with her. And I'm proud to say we got those 48 hours, and we were fortunate to remove those mops after 48 hours. So that was the story. And I used this mop packing business then again 3 times at various institutes for intractable, unsurmountable hemorrhage, the origin of which was not known. But if we would have been able to do an embolization before surgery, probably it might have made a difference. So the take-home message from this is that at times the oldest turn out to be the best. And now in the newer era, we can utilize all these newer technologies, but they have to be utilized in time before the catastrophe and not after the catastrophe.
Sir, what was the status of bladder when you re-entered?
The bladder remained intact.
Okay.
Salute to the urologist. And then we removed that smaller part of the cervix also.
Okay, that then you could separate that.
Yes. It was the bleeding which was preventing us from separating. 7.5 liters of blood means she has lost more than her total blood volume for 1.5 times. Right? I have never transfused so much in one patient in one go. From 2 a.m. to 7 a.m. 5 hours. So that was what we have been doing. We have done whatever you may call it, right or wrong. Whether what we did at the spur of the moment was right or not, I don't know. But I am glad that most of you learned people have agreed to what I did. So at least I have got some ground to stand upon if something goes wrong, if not today, after a few years. Because that patient might turn around and after 5 years come and say that, why the hell did you remove my uterus? Whose permission? I would have liked to have some few more kids. But at least I have got few experts here to back me up. Thank you very much. And on behalf of me and Dr. Chintan Bhai, I would request rest of the participants to give a big clap for all our experts around here. Thank you very much.
See, sir, good
Thank you, everyone.
Good
Can
that
I
we did
request
not
your leave?
finish. Good that we did the last case, isn't it, sir?
I don't know how good it has done.
It was very nice. Whether we manage or not, at least we could hear that certain things
That
are happening.
commendable job done by Dr. Prakash Bhai.
Not done by me, by the whole team. And that
Yes, whole team. Yeah. Whole team.
Especially the two
You-
anesthetists of Mahavir Oti. The senior most person also decided that he should have one more anesthetist with him. He called another
Okay.
anesthetist of Mahavir Oti again. That means we need some more people there.
Good.
The team is the key.
Yes, exactly, exactly. Team is one
And
of the major
persistence,
keys.
sir.
Huh?
Yeah, I will stop. And persistence, I will stop the blood by
And
any means.
God should help us at the end of 48 hours.
Who should help us?
God should help us at the end of 48 hours.
But why should it? Why should he, she, or it into bracket God wait for those 48 hours?
No, whatever it is, you didn't have bleeding, no, when you removed the mops.
Yeah, there was no bleeding.
Yeah, that is important.
Sir, ultimately, it is the Lagero and very well learning for all of us also.
Yes, so
We have to do something. Thank you very much for this
Good.
case.
Yes, thank
Very
you.
good,
Thank you
very
so
good.
much.
Thank you so much, sir. Thank you so
sir.
much.
Thank you. Thank you.
Thank you so
Thank you,
much.
sir. Thank you.
Okay, Kalpana, so we go for the
Thank you, everyone.
vote of thanks.
Yes,
Thank
thank
you so
you. Thank
much.
you, Corona. Corona.
Thank you.
Corona tha tab.
Huh.
Corona
It was
remedies.
Corona era.
Pharmaceuticals. I'm reading Corona here. That's why.
Yeah.
You are from Corona.
Oh,
Pharmaceuticals.
Corona company. Okay, okay.
Corona
So-
remedies.
Corona
Mehul,
remedies.
please
Yes,
extend my thanks to Mehul.
Yes, thank you very much, everyone, to make it successful.
Thank you.
He has helped me by supporting me that I will take care of your slides and everything. There is one question which I want to ask. Could you hear that song? Or you could
Yes.
hear that song?
Yes.
Yeah,
Yes,
sure,
sir.
sure.
Yes, sir.
The
It was
whole
written in
idea of
Hindi,
coming to
Urdu
this
and
panel
English.
discussion was to broadcast that song. Anyway, thank you very much.
Okay.
Thank you.
Thank you, moderators, for bringing out very interesting cases, and also panelists were also excited to interact with that because of that interesting case. Thank you so much. And I would like to thank all the societies who had taken efforts to join Baruch, Navsari, Surat, Valsad, and Vapi Society for joining with us for in this 122nd Happy Learning Series organized by MC Patel sir, who is the program director for this program, with the conveners' great effort, Dr. Narendra Gajar, Dr. Sneha Boya ma'am, Dr. Asha Jain ma'am, and we got the blessings from Vipul Kapadia sir and also Bhavna Sheth ma'am. Yeah, Kwamini Patel ma'am couldn't join because of her busy schedule. Anyway, her blessings is always with us, and I should also thank all the speakers who had shared their knowledge. Akash sir, Dr. Sejal Naik, ma'am, and also MC Patel sir, which was quite interesting, and we had very interesting discussions and interactions because we all are really scared about legal litigations, and we are little confused about new ART law also. And I should also thank all the chairpersons, Dr. Deepti Patel ma'am, Ravindra Korat sir, Pooja Agarwal ma'am, Nupar ma'am, Dr. Nithal Patel ma'am, and Manpreet Patel ma'am. Again, Mitali Thakur ma'am, Jagruti Desai ma'am, and Dr. Sandhya ma'am for chairing these sessions and making this session very interactive. And finally, Prakash sir for your interesting cases, and Dr. Chintan Thakkar sir for very good moderation and expert comments as usual. Very informative by Sneha Buyama and Rekha Rajendra Kumar. And thank you, panelists, once again, Dr. Praful Doshi, Dr. Quresha Qureshi, Dr. Jayashri Jaina, Dr. Pratichi, Dr. Kajal, Dr. Satyan, Dr. Darshan, Dr. Hiral Panda, Dr. Yogini Rodika, for making this program very interesting. And I also thank my coordinators, Jyoti Banglawala and Suman Sinha, for making this program a successful one. I thank Corona, who had given platform for this wonderful series. Once again, I thank MC Patel, sir, program director, who had taken maximum efforts to bring it to 122nd episode. Without his efforts, we are not here. Thank you, MC sir.
So, B Kalpana.
Yes, sir.
Yes, on behalf of Happy Learning Masterclass and on behalf of SOGO, I thank all the faculties and all the delegates, president and secretary of respective society who have joined this webinar. Thank you very much. I was busy with one more meeting. So, yes. Of course, I was listening everything, but I couldn't take part in discussion. So, sorry for the same. But thank you all for all the support, all the delegates and all the faculty.
Thank you, sir.
So, and big round of applause for two learned moderator and all the panelists, making this panel very interesting and live and vibrant. Because I was listening throughout the panel discussion. Of course, I was busy with one meeting, but I was listening. So, Prakash Bhai and Chintan.
Thank you, sir.
Yes, you have done master job.
Thank you, Manu Bhai. Thank you very much.
Yes.
Thank you, sir. Thank you.
And one thing, Prakash Bhai was abroad when I talked to him, and he was ready to moderate the panel. And I talked to Chintan also, to be in contact with Prakash Bhai, and they have made a very interesting panel. So it is commitment on part of Prakash Bhai that even if he was abroad and he has agreed to moderate the panel. So it shows his love and affection to me particularly and to Sugog.
Thank you.
सर कारवा कहीं से भी चला देते हैं सर कहीं से भी कारवा चला देते हैं
हाँ ये बराबर है लेकिन इसके लिए एक प्रतिबद्धता चाहिए वरना ये कठिन होता है और we are
special thanks to Dr.
this is our 122nd episode of
Narendra
Learning.
Thank you, madam.
And with support of all, we have continued this.
Yeah, all Tuesdays we have nowadays we are
and one thing always we conclude with that your suggestions are always welcome to make this series more informative, more fruitful and useful to our Foxian friends. So thank you very much.
Manu Bhai, thank you, sir.
Oh yes, Mehul, you can conclude now.
Yeah.
it is because of MC sir.
Special thanks to Dr. Narendra.
Thank you very much.
Dr. Jagrati Madam for so long, even
Thank you
past
so
10
much.
PM. Thanks
Thank you,
all
everyone.
seniors.
Jagruti Ben.
Thank you. Thank you.